Unit 8, the Circulatory System. Objectives. Upon completion of the unit, meet the following terminal performance objectives by verifying knowledge of the facts and principles presented through oral and written communication at a level deemed competent. 1 name. The 4 main parts of the circulatory system. Answer. The 4 main parts of the circulatory system are the heart, the blood vessels, the blood, and the lymphatic system. 2. Describe the anatomy of the heart, identifying the internal and external structures. Answer. External structures. The heart is a cone-shaped muscular organ located in the mediastinum between the lungs. It is enclosed in the pericardium, a double-layered sac with fluid that reduces friction. The base is the broad upper part, and the apex is the pointed lower tip that rests on the diaphragm. The surface has grooves called sulci that contain coronary arteries and veins. The coronary arteries supply blood to the heart muscle. Internal structures. The heart has 4 chambers. The 2 upper chambers are the right atrium and left atrium. The 2 lower chambers are the right ventricle and left ventricle. A muscular wall called the septum divides the right and left sides. The tricuspid valve is between the right atrium and right ventricle. The mitral or bicuspid valve is between the left atrium and left ventricle. The pulmonary semilunar valve is at the entrance to the pulmonary artery. The aortic semilunar valve is at the entrance to the aorta. Papillary muscles and chordae tendineae hold the valve flaps. The inner lining is the endocardium. The thick muscular layer is the myocardium. 3. Differentiate between pulmonary, systemic, and portal circulation. First, pulmonary circulation carries blood from the right ventricle through the pulmonary arteries to the lungs and returns oxygenated blood through the pulmonary veins to the left atrium. Its purpose is gas exchange. Second, systemic circulation carries oxygenated blood from the left ventricle through the aorta to all body tissues and returns deoxygenated blood through the vena cavae to the right atrium. Its purpose is to deliver oxygen and nutrients and remove waste. Third, portal circulation is a special part of systemic circulation. The hepatic portal system carries blood from the digestive organs through the portal vein to the liver before it returns to the heart. Its purpose is to process nutrients and filter toxins before blood enters general circulation. 4. Describe the heart sounds, including the actions producing the sounds, and where they can be auscultated. Answer. The heart sounds are called lubbed up. The first sound, lub, is produced by the closing of the atrioventricular valves, the tricuspid and mitral valves, at the start of ventricular systole. The second sound, dup, is produced by the closing of the semilunar valves, the pulmonary and aortic valves, at the start of ventricular diastole. Auscultation sites. The tricuspid valve is heard at the 5th intercostal space at the left sternal border. The mitral valve is heard at the 5th intercostal space at the left midclavicular line, at the apex. The pulmonary valve is heard at the 2nd intercostal space at the left sternal border. The aortic valve is heard at the 2nd intercostal space at the right sternal border. 5. Locate the pacemaker, explain its action, and tell how the heart rate is influenced by the body. Answer. The natural pacemaker is the sinoatrial node, located in the upper wall of the right atrium near the opening of the superior vena cava. The sinoatrial node generates electrical impulses that start each heartbeat and set the basic rhythm. The impulse travels to the atrioventricular node, then through the bundle of His and Purkinje fibers to cause ventricular contraction. Heart rate is influenced by the body through the nervous system and hormones. The accelerator nerves of the sympathetic nervous system and the hormone epinephrine increase heart rate. The vagus nerve of the parasympathetic nervous system decreases heart rate. Other factors include body temperature, blood pressure, carbon dioxide level, emotions, and exercise. 6. Explain how the cardiac conditions of heart block and fibrillation relate to the pacemaker. Answer. Heart block occurs when the electrical impulse from the sinoatrial node is delayed or blocked at the atrioventricular node or in the bundle of His. This causes the ventricles to beat more slowly than the atria or independently of them. Fibrillation is a rapid, uncoordinated contraction of muscle fibers. Atrial fibrillation occurs when the atria quiver, instead of contracting properly, because impulses do not start from the sinoatrial node. Ventricular fibrillation occurs when the ventricles quiver and cannot pump blood, which is life-threatening. Both conditions mean the pacemaker is not controlling the rhythm correctly. 7. Explain the purpose of an artificial pacemaker and how it functions. Answer. The purpose of an artificial pacemaker is to provide electrical stimulation to the heart when the natural pacemaker fails, or when heart block prevents impulses from reaching the ventricles. It maintains a regular heart rate and rhythm. An artificial pacemaker functions by delivering small electrical impulses to the heart muscle through one or more leads placed in the heart chambers. A battery-powered generator is implanted under the skin. The pacemaker can be set to fire at a fixed rate, or to sense the heart's own electrical activity and fire only when needed. 8. Name the 5 types of blood vessels and their purpose and structure. Answer. First, arteries carry blood away from the heart to the tissues. They have thick, muscular, elastic walls to withstand high pressure. The largest artery is the aorta. Second, arterioles are small branches of arteries. The vena cavae are the largest veins. 9. Describe the function of a capillary bed. Their purpose is to allow exchange of oxygen, nutrients, and waste between blood and tissue cells. Its function is to allow the exchange of substances between the blood and body cells. Oxygen and nutrients diffuse out of the blood into the tissue fluid and cells. Carbon dioxide and waste products diffuse from the cells into the blood. Blood flow through a capillary bed is regulated by precapillary sphincters that open and close. 10. Trace the pathway of blood through the pulmonary and systemic circulation. Its function is to allow the exchange of substances between the blood and body cells. Oxygen and nutrients diffuse out of the blood into the tissue fluid and cells. Carbon dioxide and waste products diffuse from the cells into the blood. Blood flow through a capillary bed is regulated by precapillary sphincters that open and close based on tissue needs. Oxygenated blood returns through the pulmonary veins to the left atrium. Pulmonary circulation. Deoxygenated blood enters the right atrium from the superior and inferior vena cavae. The aorta branches into arteries that carry blood to all body tissues. Blood gives up oxygen and picks up carbon dioxide in the capillaries. In the lungs, blood picks up oxygen and releases carbon dioxide. 11. Explain the function and structure of the lymphatic system. Answer. The function of the lymphatic system is to return excess tissue fluid to the bloodstream, to filter lymph and remove bacteria. Answer. The function of the lymphatic system is to return excess tissue fluid to the bloodstream, to filter. The structure includes lymphatic vessels that begin as lymphatic capillaries in the tissues and join to form larger. Blood gives up oxygen and picks up carbon dioxide in the capillaries. Lymph flows through lymph nodes, which are small oval structures that filter lymph and contain white blood cells. Lymph flows through lymph nodes, which are small oval structures that filter lymph and contain white blood cells. Answer. The function of the lymphatic system is to return excess tissue fluid to the bloodstream, to filter lymph and remove bacteria and cell debris, and to house lymphocytes that provide immunity. Lymph returns to the bloodstream through the thoracic duct and right lymphatic duct into the subclavian veins. Lymph flows through lymph nodes, which are small oval structures that filter lymph and contain white blood cells. Other organs include the spleen, which filters blood and stores lymphocytes, the thymus, which processes T lymphocytes, and the tonsils. Lymph returns to the bloodstream through the thoracic duct and right lymphatic duct into the subclavian veins. 12. Name the components of whole blood and the role of each. Answer. Whole blood has 2 main parts: plasma and formed elements. First, plasma. The liquid portion, about 55% of blood volume. It is 91% water and contains proteins, nutrients, hormones, gases, and waste. It transports substances and helps maintain blood pressure and volume. Second, erythrocytes, red blood cells that contain hemoglobin. Their role is to carry oxygen from the lungs to the tissues and carry some carbon dioxide back to the lungs. Third, leukocytes, white blood cells that fight infection. Types include neutrophils, lymphocytes, monocytes, eosinophils, and basophils. Fourth, thrombocytes, platelets that are cell fragments needed for blood clotting. 13. Describe the clotting process. Answer. The clotting process, called hemostasis, has 3 steps. First, vascular spasm. The injured blood vessel constricts to reduce blood loss. Second, platelet plug formation. Platelets stick to the damaged vessel wall and to each other to form a temporary plug. Third, coagulation. Clotting factors in the plasma are activated in a sequence. Prothrombin is converted to thrombin. Thrombin converts fibrinogen to fibrin. Fibrin forms a mesh that traps blood cells and forms a stable clot. After healing, The clot is dissolved by fibrinolysis. 14. Name the blood types and explain their importance to recipients of transfusions. Answer. The four main blood types in the ABO system are type A, type B, type AB, and type O. Type A has antigens and anti-B antibodies. Type B has B antigens and anti-A antibodies. Type AB has both A and B antigens and no antibodies. Type O has no antigens and both anti-A and anti-B antibodies. This is important for transfusions because the recipient's plasma antibodies must be compatible with the donor's red blood cell antigens. If incompatible blood is given, the antibodies will attack the donor cells, causing clumping and a transfusion reaction. Type O is the universal donor for red cells. Type AB is the universal recipient. 15. Explain the importance of the Rh factor in pregnancy and transfusions. Answer. The Rh factor is an antigen on red blood cells. If the antigen is present, the blood is Rh positive. If absent, the blood is Rh negative. In transfusions, an Rh negative person should not receive Rh positive blood. The first exposure may cause the recipient to make anti-Rh antibodies. A second exposure can cause a severe reaction. In pregnancy, if an Rh negative mother carries an Rh positive fetus, her blood can form antibodies against the fetal cells. This can cause hemolytic disease of the newborn in later pregnancies. An injection of Rh immune globulin can prevent antibody formation. 16. Identify 9 cardiovascular tests and the reasons for giving them. Answer. First, electrocardiograph. Records the electrical activity of the heart to detect arrhythmias, ischemia, or myocardial infarction. Second, Holter monitor. Provides continuous electrocardiograph recording for 24 hours or more to detect irregular heartbeats. Third, angioplasty. A procedure that uses a balloon catheter to open blocked arteries. It is done to restore blood flow in coronary artery disease. Fourth, arteriography or angiography. An X-ray study of arteries after dye injection to locate blockages. Fifth, multiple gated acquisition scan. A nuclear medicine test that evaluates heart function and wall motion. Sixth, echocardiogram. Uses sound waves to show heart structure and motion and to check valves. Seventh, stress test. Monitors the heart during exercise to detect coronary artery disease. Eighth, blood pressure measurement. Checks for hypertension or hypotension. Ninth, lipid profile. Measures cholesterol and triglycerides to assess risk for atherosclerosis. 17. Describe 26 diseases or disorders of the circulatory system. Answer. First, arteriosclerosis. Hardening and thickening of artery walls. Second, atherosclerosis. Buildup of fatty plaque in arteries. Third, aneurysm. A bulge in a weakened artery wall. Fourth, angina. Chest pain due to reduced blood flow to the heart muscle. Fifth, arrhythmias. Irregular heartbeats. Sixth, bradycardia. Heart rate slower than 60 beats per minute. Seventh, tachycardia. Heart rate faster than 100 beats per minute. Eighth, heart block. Delay or blockage of electrical conduction in the heart. Ninth, fibrillation. Rapid, uncoordinated contractions of the atria or ventricles. 10th, myocardial infarction. Heart attack due to blocked coronary artery. 11th, congestive heart failure. The heart cannot pump enough blood to meet body needs. 12th, coronary artery disease. Narrowing of coronary arteries by plaque. 13th, hypertension, high blood pressure. 14th, hypotension, low blood pressure. 15th, ischemia, lack of blood supply to tissue. 16th, infarction, tissue death due to lack of blood supply. 17th, cerebrovascular accident, stroke caused by blocked or ruptured brain vessel. 18th, transient ischemic attack, temporary blockage of blood flow to the brain. 19th, embolism, a clot or other material that travels and blocks a vessel. 20th, thrombosis, formation of a clot in a blood vessel. 21st, thrombophlebitis, inflammation of a vein with clot formation. 22nd, phlebitis, inflammation of a vein. 23rd, varicose veins, swollen twisted veins due to faulty valves. 24th, hemorrhage, excessive bleeding. 25th, anemia, low number of red blood cells or low hemoglobin. 26th, leukemia, cancer of white blood cells. Acute leukemia progresses rapidly. Chronic leukemia progresses slowly. 18. Spell and define, using the glossary at the back of the text, all the words to know in this unit. Answer. Accelerator, a nerve that increases heart rate. Arteriosclerosis, hardening of the arteries. Acute phase, the early stage of a disease. Artery, a vessel that carries blood away from the heart. Adenitis, inflammation of a gland or lymph node. Atherosclerosis, fatty plaque buildup in arteries. Ambulatory, able to walk or not confined to bed. Atrium, an upper chamber of the heart. Plural is atria. Anemia, condition of low red blood cells or hemoglobin. Atrioventricular node, the AV node that delays and relays the heart's electrical impulse. Aneurysm, a ballooning of a blood vessel wall. Bicuspid, having two cusps, refers to the mitral valve. Angina, chest pain from lack of oxygen to the heart. Bradycardia, slow heart rate, less than 60 beats per minute. Angioplasty, procedure to open a blocked blood vessel. Capillary, the smallest blood vessel where exchange occurs. Anticoagulant, a substance that prevents blood clotting. Cardiac, relating to the heart. Aorta, the largest artery, carries blood from the left ventricle. Cardiovascular, relating to the heart and blood vessels. Arrhythmias, irregular heart rhythms. Singular is arrhythmia. Cerebrovascular accident, stroke, damage to brain from blocked or ruptured vessel. Arterioles, small branches of arteries. Chronic leukemia, slowly progressing cancer of white blood cells. Compatible, able to be mixed without a reaction, used for blood. Myocardium, the muscular layer of the heart wall. Congestive heart failure, condition where the heart cannot pump effectively. Nodes, small masses of tissue, such as lymph nodes or heart nodes. Coronary, relating to the arteries that supply the heart. Pacemaker, the sinoatrial node or an artificial device that sets heart rhythm. Crossmatch, test to check donor and recipient blood compatibility. Papillary muscles, muscles in the ventricles that hold valve cords. Diastole, the relaxation phase of the heart cycle. Pericardium, the sac surrounding the heart. Electrocardiograph, ECG, a machine that records heart electrical activity. Phlebitis, inflammation of a vein. Embolism, a clot or substance that travels and blocks a vessel. Plasma, the liquid part of blood. Endocardium, the inner lining of the heart. Platelet, a cell fragment that helps blood clot, also called thrombocyte. Erythrocyte, a red blood cell. Portal, relating to the portal vein system that goes to the liver. Exudate, fluid that leaks from blood vessels during inflammation. Rh factor, an antigen on red blood cells that can cause reactions. Fibrillation, rapid, uncoordinated contractions of heart muscle. Sinoatrial node, the SA node, the natural pacemaker of the heart. Heart block, delay or interruption of electrical conduction in the heart. Semilunar, half-moon-shaped, refers to the aortic and pulmonary valves. Hemoglobin, the protein in red blood cells that carries oxygen. Septum, a dividing wall between the right and left sides of the heart. Hemorrhage, severe bleeding. Sickle cell anemia, inherited disorder with abnormal crescent-shaped red cells. Holter monitor, portable device for continuous electrocardiograph recording. Spleen, organ that filters blood and stores lymphocytes. Hypertension, high blood pressure. Stasis ulcer, skin sore due to poor venous blood flow. Hypotension, low blood pressure. Systole, the contraction phase of the heart cycle. Infarction, tissue death from lack of blood supply. Tachycardia, fast heart rate over 100 beats per minute. Ischemia, reduced blood supply to tissue. Thrombophlebitis, vein inflammation with clot formation. Leukemia, cancer of blood forming tissues with abnormal white cells. Thrombosis, formation of a blood clot in a vessel. Leukocyte, a white blood cell. Transfusion, transfer of blood or blood products into a vein. Lubbed up, the sounds of the heart valves closing. Transient ischemic attack, brief stroke-like symptoms that resolve. Lymph, fluid in the lymphatic vessels. Tricuspid, having 3 cusps, refers to the right atrioventricular valve. Lymphatic system, network of vessels and organs that carry lymph and fight infection. Vagus, a cranial nerve that slows the heart rate. Lymphocyte, a type of white blood cell involved in immunity. Valve, a structure that permits one-way flow, as in the heart or veins. Metastasize, to spread from one part of the body to another, as in cancer. Varicose, swollen and twisted, usually refers to veins. Mitral, relating to the bicuspid valve between left atrium and ventricle. Vein, a vessel that carries blood toward the heart. Multiple gated acquisition scan, MUGA scan, tests heart pumping function. Vena cava, a large vein returning blood to the right atrium. Plural is vena cava. Murmur, an abnormal heart sound. Ventricle, a lower chamber of the heart. Myocardial infarction, MI, death of heart muscle, due to blocked artery. Venule, a small vein that collects blood from capillaries. The circulatory system transports oxygen and nutrients to the body's cells and carbon dioxide and other waste products from the cells to be eliminated from the body. The blood, which flows through a closed circuit of vessels, is the vehicle for transportation. A very efficient muscle, the heart, is the force behind the system. A few minutes interruption of the circulatory system can result in death. The circulatory system is composed of 4 main parts. 1. A pump, the heart. 2. The plumbing, the blood vessels. 3. The circulating fluid, the blood. And 4. An auxiliary fluid system, the lymphatic system. Each day, the heart pumps the equivalent of 4,000 gallons of blood at 40 miles per hour through an estimated 70,000 miles of blood vessels. To achieve this, the heart must forcefully contract, squeezing out blood at an average rate of 72 times per minute, or about 100,000 times each day. In a year, the heart will contract 40 million times, resting only a fraction of a second between beats. To appreciate this phenomenal organ, alternately open and close your fist a little more often than once a second for just 1 minute by the clock. You will notice that not only your hand but also your forearm muscles begin to tire. Scientists have estimated that the work of the heart is about equal to the energy needed to lift a 10-pound weight 3 feet off the floor, twice a minute for a lifetime. The condition of the blood vessels and the composition of the blood are major factors in the amount of force the heart must exert to circulate the blood. The heart. The heart is about the size of a clenched fist and is located behind the sternum, between the lungs, with 2/3 of it on the left side of the chest. It is constructed of several layers of muscles arranged in both circular and spiral fashion. When the muscles contract, blood is squeezed out of the heart chambers. During the relaxation phase, the heart fills with blood entering from the great veins. There is a considerable difference in heart size across the phases, as shown in Figure 1199. The contraction phase is known as systole, and the relaxation phase is called diastole. Systole is the period when the heart exerts the greatest pressure on the blood. This corresponds to the beat phase of the heart, and can be heard over the heart with a stethoscope or felt as the pulse in an artery. The systolic pressure can be determined by measurement with blood pressure equipment, and is represented by the larger or top number of the blood pressure reading. Diastole is the period of least pressure, and is the time when the heart rests. This phase cannot be felt as a beat, but the diastolic pressure can be heard and determined by measurement. It is represented by the smaller or bottom number of the blood pressure reading. The outer wall of the heart is surrounded by a sac called the pericardium. Like the pleura of the lungs, the pericardium has one layer called the parietal, which lines the sac, and another layer, the visceral, which covers the heart itself. The pericardial fluid between the layers prevents friction when the heart beats. The heart structure does not receive its blood supply from the blood pumped through its interior, but from several small blood vessels which cover the surface of the heart, Figure 11-100. These blood vessels, called the coronary arteries and veins, carry oxygen, nutrients, and waste products to and from the heart muscle. The right and left coronary arteries enter the top of the heart from the aorta. Blood from the coronary veins returns to the right atrium by a small opening called the coronary sinus. The muscle wall of the heart is called the myocardium. The wall of the left lower chamber is thicker because it must pump blood through the entire general or systemic circulation, as discussed later. A tissue known as endocardium lines the interior surface of the heart, Figure 11-101. The lining also covers the heart valves and the interior surface of the blood vessels to allow for the smooth flow of blood. Internally, the heart is a double pump, divided into a right and left side by a muscular wall called a septum. The septum prevents the blood on the right side from mixing with that on the left. The sides are further divided into upper and lower chambers. The right upper chamber is called the right atrium, the lower, the right ventricle. The left side is similarly divided into a left atrium and left ventricle. The chambers are separated by one-way valves, which keep the blood flowing in the right direction. The tricuspid valve is between the right atrium and ventricle, and the bicuspid or mitral valve is between the left atrium and ventricle. Papillary muscles are attached by cords to the undersurfaces of the valve cusps or leaflets. When the atria contract, the papillary muscles also contract to pull open the valves, allowing the blood from the atria to enter the empty ventricles. Then the muscles relax, which allows the valves to close as the atria refill. The closed valves prevent the blood from re-entering the atria when the ventricles contract. At the contraction of the ventricles, blood is forced out to the great arteries of the body. The right ventricle sends the blood through a semilunar valve into the pulmonary artery on its way through the pulmonary circulation in the lungs for a supply of oxygen. The left ventricle forces the blood past a semilunar valve into the aorta to be distributed throughout the general or systemic circulation of the body. A specific sequence of events occurs within the body as the blood is circulated. Blood flow occurs in two distinct patterns: pulmonary circulation between the heart and the lungs, and systemic circulation between the heart and the rest of the body. Figure 11.102 and the following material describe the flow of blood through the pulmonary system. 1. Deoxygenated blood without oxygen is carried in the superior vena cava from the arms, neck, and head, and carried in the inferior vena cava from the lower extremities and internal organs, except the heart itself. This blood enters the right atrium. Circulation from the heart also empties into the atrium by way of the coronary sinus. The right atrium contracts, squeezing blood through the tricuspid valve, which is opened by the papillary muscles, into the right ventricle. Then the valve closes. 2. The right ventricle contracts, sending blood out through the pulmonary semilunar valve into the pulmonary artery. Remember, this artery carries deoxygenated blood, but is still an artery because it is leaving the heart. 3. The pulmonary artery divides into a right and left branch, one going to each lung. The division continues into smaller arteries, arterioles, and then to the capillaries in the alveolar sacs. Here, the deoxygenated blood gives up its carbon dioxide and picks up oxygen. 4. With a fresh supply of oxygen, the capillaries join the venules, then become veins and re-enter the heart as 4 pulmonary veins, 2 from each lung, emptying into the left atrium. This is the only time veins carry oxygenated blood, but they are still veins because they are returning to the heart. 5. The left atrium contracts, forcing blood through the mitral or bicuspid valve into the left ventricle, and the valve immediately closes. 6. The left ventricle contracts forcefully, sending blood racing out of the heart past the aortic semilunar valve into the aorta. The action of the chambers of the heart just described occurs simultaneously in both sides of the heart. In other words, both atria contract at the same time, as do the ventricles. The chambers must work in unison or blood being pushed forward would have no place to go. This situation does occur in certain cardiovascular disorders and will be discussed later. The total action just described occurs each time the heart beats. The physician listens at specific locations on the chest wall to hear specific functions of the heart. Figure 11-100. 3 illustrates the anatomical location of the valves and the corresponding auscultatory areas. When a stethoscope is used to listen to the heartbeat, 2 distinct sounds can be heard. They are referred to as the lubed-up sounds. The lub sound, which is heard first, is caused by the valves slamming shut between the atria and the ventricles. The physician refers to this sound as the S1. It is heard loudest at the apex of the heart. The dup, heard second, is shorter and higher pitched. It is caused by the semilunar valves closing in the aorta and the pulmonary arteries. This sound is known as the S2. It is loudest at the second intercostal space on each side of the sternum. With a little practice, the valve's condition and level of function can be evaluated from their sounds. Certain conditions cause changes in the action of the heart valves. Normally, the right heart valves close a fraction of a second before the left, due to the lower pressure in the right side of the heart. When the ventricles are distended, an audible vibration may occur, which is referred to as an S3 or a ventricular gallop. Occasionally, just before S1 at the end of diastole, the atria may contract, forcing blood into an already filled ventricle. This causes a rise in the ventricular pressure and vibrations known as atrial gallop, or S4. The pacemaker. The normal heart beats rhythmically, as long as the cells receive the correct balance of sodium, calcium, and potassium, and an adequate supply of oxygen and nutrients. Another essential element is the spark, from the group of nerve cells in the right atrium called the sinoatrial or SA node, also called the pacemaker. Figure 11-104. The node generates the electrical impulse that starts each wave of muscle contraction in the heart. The impulse in the right atrium spreads over the muscles of both atria, causing them to contract simultaneously, sending blood into the ventricles. The impulse apparently triggers the atrioventricular or AV node located between the atria and the ventricles, even though there is no direct connection between the nodes. The AV node has nerve fibers that extend through the septum and are called the bundle of His. The bundle divides into a right and left branch, infiltrating the muscles of each ventricle with a system of Purkinje fibers. The AV node causes the contraction of the ventricles. Rhythm disorders. The self-generating impulse of the heart is one of the body's miracles. Even if the heart were removed from the body, it would continue to beat as long as it was supplied with the necessary nutrients. In a cardiac condition known as heart block, there is an interruption in the message from the sinoatrial node to the atrioventricular node. The interruption can occur in varying degrees. The abnormal rhythm patterns can be viewed on an electrocardiograph, which is a heart action recording or EKG. First-degree block is characterized by a momentary delay at the atrioventricular node before the impulse is transmitted to the ventricles. Second-degree block can be of two forms. One occurs in cycles of delayed impulses until the sinoatrial node fails to conduct to the atrioventricular node, then returns to near normal. A second form is characterized by a pattern of only every second, third, or fourth impulse being conducted to the ventricles. This causes a marked decrease in heart output and is usually progressive to the third degree. Third-degree heart block is known as complete heart block. There is no impulse carried over from the pacemaker. Because the heart is essential to life, there is a built-in safety factor. The atria continue to beat at 72 times per minute, while the ventricles contract independently at about half the atrial rate, adequate to sustain life but resulting in a severe decrease in cardiac output. Other rhythm disorders are known as arrhythmias, meaning absence of rhythm. Premature contractions cause arrhythmia and occur when an area of the heart, not the sinoatrial node, sparks and stimulates a contraction of the rest of the myocardium. This area is known as an ectopic pacemaker, meaning abnormal place. There are 3 types of premature contractions, each identified by the area of its location: atrial, ventricular, or atrioventricular junctional. Atrial premature contractions are known as PACs, premature atrial contractions, and cause the atria to contract ahead of the anticipated time. Premature junctional contractions, PJS, have the ectopic pacemaker focused at the junction of the atrioventricular node and the bundle of His. Usually PACs and PJS are of no clinical significance and are usually caused by nicotine, caffeine, fatigue, or tension. Premature ventricular contractions, PVCs, are a different matter. They originate in the ventricle and cause contraction ahead of the next anticipated beat. They can be benign or deadly. If frequent, 5 to 6 per minute or in pairs, they may require immediate intervention to decrease the irritability of the cardiac muscle to maintain cardiac output. If the PVCs occur every other beat, it is a bigeminal rhythm. If they occur every third beat, it is a trigeminal rhythm. PVCs can be caused by electrolyte and acid-base imbalance, drug therapy, myocardial infarction, C diseases, or oxygen deficit. In another malfunction of the impulse mechanism known as ventricular fibrillation, the rhythm breaks down and the muscle fibers contract at random without coordination. This results in very ineffective heart action and is a life-threatening condition. An electrical device called a defibrillator is used to discharge a strong electrical current into the patient's heart through electrode paddles held against the bare chest wall. The shock should interfere with the uncoordinated action and allow the sinoatrial node to resume its control. Medications such as digoxin are often effective in controlling atrial fibrillation. Artificial pacemaker. When the natural pacemaker of the heart fails to maintain a normal heart rate and cardiac drug therapy designed to cause effective, regular beats fails to correct the situation, an artificial pacemaker may be indicated. The device consists of a small battery-powered pulse generator with electrode catheters, figure 11-105. The electrodes are inserted into a vein and threaded through the vena cava, one to the right atrium, the other into the right ventricle at the apex. The procedure is accomplished while observing the path of the electrodes by fluoroscopy. The action of the heart throughout the procedure, and for at least the first 24 hours following, is monitored carefully by frequent electrocardiograph tracings, ECG. The stimulation threshold of the pacemaker to maintain myocardial contractions is determined by noting the number of milliamperes, which produce the desired QRS complex, which is the ECG tracing of contraction. This milliamperage and the desired rate can be set in the pacemaker with a handheld radio transmitter. It should be noted that when the heart is totally dependent on artificial pacing, the heart rate may always be that which is artificially set. Newer artificial pacemakers can increase the rate to meet the needs of increased activity by sensing body motion. A pacemaker can be attached temporarily to the chest wall, upper arm, or waist. It can also be permanently inserted surgically into a muscular pocket on the chest wall. Permanent units are self-contained and will operate for about 3 to as many as 12 years. Pacemakers can also be of either the fixed or the demand type. Fixed units fire continuously at a predetermined rate. Demand types sense the person's own rate and fire only when required. An external unit can be programmed to change the mode of firing of some implanted types. Battery failure requires replacement of the entire generating unit. Pacemakers are of benefit to patients with a slow, irregular heart rhythm, complete heart block, or a slow ventricular rate due to congenital or disease conditions. Controlling the rate. 2 nerves, the vagus and the accelerator, have fibers in the heart muscle and exert some control over the natural rate of the heartbeat, figure 11 to 106. The vagus nerve, also called the decelerator, slows down the heart rate, while the accelerator nerve increases the rate. The nerves, however, are stimulated by many things. Heart rate can increase as a result of fear, anger, or excitement, and can decrease with severe depression. The amount of oxygen, carbon dioxide, and electrolytes, sodium, potassium, magnesium, phosphates, and chlorides, present in the blood affect the rate of the heart. A heart rate which is consistently rapid, over 100 beats per minute, is known as tachycardia. When the rate is consistently slow, less than 60 beats per minute, it is referred to as bradycardia. The blood vessels. Blood vessels are divided into 3 main types: arteries, veins, and capillaries, figure 11-107. Arteries. An artery always carries blood away from the heart and usually carries fresh, oxygenated blood. The one exception is the pulmonary artery, which leaves the right ventricle of the heart on its way to the lungs to pick up oxygen. Arteries are constructed with layers of elastic fibers that allow the walls to expand and recoil in response to the injection of blood when the ventricles contract. In the systemic circulation, this action causes a wave-like effect within the arteries, which can be felt as the pulse at the pulse points of the body. Figure 11-108 shows the main arteries of the human body. In areas where arteries lie over firm or bony structures, such as at the wrist, the side of the neck, or inner elbow surface, the pulse can be felt if the artery is pressed against the underlying structure. The major arteries of the body are aorta, the large artery exiting the left ventricle of the heart and extending down the center of the body. All other arteries branch off the aorta. Carotid extends up the side of the neck into the head. Pulmonary extends from the right ventricle to the lungs. Brachial extends down the arm. Radial extends on the thumb side of the forearm. Ulnar extends on the little finger side of the forearm. Common iliac branches off the abdominal aorta and extends down through the pelvis. Femoral extends through the thigh. Tibial extends from the femoral through the lower leg. Dorsalis pedis extends along the top of the foot. As the arteries divide and branch off into smaller and smaller vessels, they become known as arterioles. Eventually, the arterioles join the microscopic blood vessels known as capillaries. When the blood enters the vast network of capillaries, called a capillary bed, it is so dispersed that the rate of flow is reduced to a slow trickle, permitting time for oxygen and nutrients to enter the tissue cells in exchange for carbon dioxide and waste products, figure 11-109. Capillary walls are thin, one-cell structures that allow the passage of molecules into the fluid-filled tissue spaces surrounding the cells. The molecules pass through the fluid to enter either the cell or the capillary. Tiny openings in the capillary walls permit white blood cells to leave the blood and enter the fluid of the tissue spaces to destroy bacteria. Plasma also seeps through the capillary walls, adding to the amount of tissue fluid. Excess fluid, certain waste products, and other substances are removed by an adjoining capillary of the lymphatic system, an action that will be discussed later in this unit. The vast number of capillaries within the body would be more than capable of holding all the body's supply of blood. Therefore, an automatic system is in effect that permits a group of cells being served by one section of a capillary bed to receive blood for only a short period of time. Then another section is served, and the first section must wait for another turn. This control is maintained by a series of capillary sphincters, which open and close the entrances to the capillary beds. Body cells, in order of importance, have a predetermined priority for receiving the available blood supply. At any given time, only 2 of the 3 major body functions can be served. The brain and other central nervous system structures always have priority. Next come the skeletal muscles that enable us to move and therefore provide a degree of protection to the body with the fight or flight options. Last is the supply to the internal organs of the digestive system. This means that if you have eaten recently and you decide to run, swim, or exercise strenuously, Your stomach may complain with cramps because the digestive system is not getting enough blood supply to digest its contents. When the blood leaves the capillary bed, it is carrying carbon dioxide and waste products from the cells to be circulated to the proper organ for disposal. Capillaries join with venules, which are tiny branches of the veins. As they return blood toward the heart, venules join together forming veins, which eventually enter the heart, from the lower body by the inferior vena cava, and from the upper body by the superior vena cava. Veins. Veins are similar to arteries in construction, except that the walls are thinner, and they lack the elastic fiber lining that lets arteries alter the size of their openings. The pressure that is present in arteries is absent in veins, and therefore they can collapse when they are not filled. The major veins of the body are shown in Figure 11-110. The major veins of the body are tibial from the feet to the thigh, saphenous in the thigh from the knee into the pelvis, femoral in the thigh from the knee into the pelvis, common iliac from the saphenous and femoral to the inferior vena cava. Inferior vena cava, all lower body veins to the right atrium of the heart, jugular from the head and neck, brachial from the arm to the brachiocephalic vein, cephalic from the arm to the brachiocephalic vein, superior vena cava, all upper body veins to the right atrium of the heart, pulmonary veins from the lungs to the left atrium. Veins carry deoxygenated blood back to the heart to be sent to the lungs for exhaling carbon dioxide and to pick up a new supply of oxygen. Every time the heart beats, blood is forced through the arteries and arterioles to the capillaries, where the pressure from the heart is dissipated in the vast capillary network. With each successive beat, additional blood is forced through the capillaries into the venules and veins, which move it back toward the heart. Special valve structures are located throughout the veins to maintain the flow of blood in the proper direction, Figure 11-111. Veins in the lower extremities especially contain many valves since they are returning blood uphill, so to speak. During the relaxation phase of the heartbeat, the venous blood could flow back toward the capillaries, but the valves close as relaxation begins, and the blood is trapped in the veins until the following beat forces it to move forward. Another factor helps move blood in veins back to the heart. The veins of the extremities are located in and around the large skeletal muscles. When the muscles contract, they squeeze the veins, thereby aiding in the movement of the blood. Figure 11-112. Blood flows to every cell in the body through the systemic circulation. Refer to Figures 11-108 and 11-110. As you read the following description of the flow through the major arteries and veins. 1. As the blood leaves the left ventricle, it enters the huge aorta. Immediately, the right and left coronary arteries to the heart exit from the aorta at its arch. Other great arteries, the common carotid, the subclavian, and the innominate, which becomes the brachial and radial arteries of the arm, also exit from the arch, divide into right and left branches, and supply blood to the head, neck, and upper extremities. 2. As the aorta descends through the body, the thoracic and abdominal portions give origin to the large arteries supplying the organs of the thorax and abdomen. 3. When the aorta reaches the level of the fourth lumbar vertebra, it divides into two large common iliac arteries, with the external branch descending down the legs and the internal branch leading to the pelvic organs and genitalia, meaning external sex organs. 4. The external branch of the iliac artery becomes the femoral artery in the thigh and continues down the leg as the tibial branch. 5. Eventually, all systemic arteries throughout the body subdivide until they become arterioles and then join the capillaries. In this circuit, the capillaries deliver the oxygen, water, and nutrients to the body's cells and pick up the cell's carbon dioxide and wastes. 6. Upon leaving the capillaries, the blood is considered deoxygenated. The capillaries join venules, which eventually become veins. 7. The major lower extremity veins are the anterior and posterior tibial, the small and great saphenous, the popliteal, and the femoral. These join with pelvic veins and enter the inferior vena cava. 8. The major veins of the upper extremities are the basilic, median, and cephalic. These join with the subclavian, internal and external jugular, the innominate, and the sinuses from the head to enter the superior vena cava. 9. The superior vena cava and inferior vena cava empty into the right atrium of the heart, and systemic circulation is completed. Portal circulation. The preceding was a simplified description of the body's general circulation. However, there is another circuit that leaves and re-enters the system just described. It is called the portal circulation, figure 11.113. The details of its function are beyond the scope of this text, but it can be described in general terms. As the aorta descends through the abdomen, arteries branch off to the internal organs, the stomach, liver, spleen, pancreas, kidneys, etc. Each organ receives substances on which it reacts. These substances may be sugar, salt, hormones, a toxic chemical, nutrients, waste products from the cells of other organs, everything you eat, drink, inhale, or inject into your body. Eventually, these substances enter the circulatory system. The blood leaving certain organs, ones without a pair, empties into the special portal circulation and eventually becomes the portal vein. This vein goes to the liver to permit the blood from the large and small intestines, stomach, pancreas, and spleen to come into contact with the liver's specialized cells. Many life-preserving functions are performed by these liver cells. For example, here nutrients that enter the blood from the digestive system are altered, stored, and/or released into the main circulatory system as needed. After passing through the liver, the blood is carried by the venous system to the inferior vena cava and is recirculated. The lymphatic system consists of lymph, a straw-colored fluid similar to blood plasma, lymph nodes, lymph vessels, and the spleen. In addition, the lymphatic tissue, which produces lymphocytes, a type of blood cell, is often considered to be part of the system. This includes the tonsils, the thymus gland, and the intestinal lymphoid tissue. Lymph. Lymph is composed of blood plasma that filters out of the capillaries, lymphocytes, hormones, and many other substances, which are the products of cellular activity, such as water, digested nutrients, salts, oxygen, carbon dioxide, and urea, figure 11-114. It is a continuous forming process. Lymph fills the spaces between the cells and is also referred to as intercellular or interstitial fluid. Lymph acts as the bridge between cells and capillaries. Lymph is moved through the lymph vessels primarily by contraction of the skeletal muscles. There is no pump like the heart to move lymph. Lymph vessels are constructed like veins, however, with valves to prevent the backflow of fluid. Lymph vessels. Vessels carrying lymph are located throughout the body, somewhat like veins. Lymphatic capillaries absorb fluid and other substances from the tissues and return it to the circulatory system. Figure 11-115. However, it is a one-way system only, from the cells toward the heart. There are no separate vessels bringing lymph to the cells. The vast network of lymph capillaries joins to form small lymph vessels that in turn form larger vessels called lymphatics. Lymphatics eventually form two main ducts. The right lymphatic duct receives lymph from the right side of the head, the right arm, and the upper right trunk. The thoracic duct receives lymph from the rest of the body, figure 11-116. Lymph nodes. Lymph nodes are small round or oval structures located usually in clusters along the lymph vessels at various places in the body. Lymph enters the nodes from 4 afferent lymph vessels, filters through a mesh of sinuses, and leaves by way of a single efferent vessel. Lymphocytes, a type of white blood cell, are derived from stem cells in the bone marrow. They enter the bloodstream and go to the lymph tissue to live. Their action is essential to the immune system of the body. When needed, they divide by mitosis, greatly increasing in number. Phagocytes, another type of white blood cell, can also be found in lymph nodes. The structure of the nodes and the cell's function purify the lymph by removing harmful substances such as bacteria or malignant cells. The nodes increase and decrease in size in relation to the amount of material being filtered. In acute infections, they become swollen and tender due to the collection of cells gathered to destroy the invading substances. This condition is known as adenitis. With extensive involvement, the node may break down and an abscess will form. Physicians palpate for nodes when patients have infectious conditions, or when a malignancy is known or suspected. With malignancy, the cancer cells are abnormal, and so are identified by the cells in the lymph node to be removed from the circulating fluid. As more cells accumulate, the node becomes enlarged and is therefore palpable. Early detection of lymph node involvement is critical to the prognosis of patients with cancer, for it is through the lymphatic system that a malignancy often metastasizes, meaning spreads to other sites. The extent of lymph node involvement is an important indicator of the ultimate prognosis of the patient. The spleen. The spleen is an organ composed of lymphatic tissue, lying just beneath the left side of the diaphragm, in back of the upper portion of the stomach. The spleen produces lymphocytes, stores red blood cells, keeps the appropriate balance between cells and plasma in the blood, and removes and destroys worn-out red cells. The organ functions like a large lymph node. It is soft and elastic and varies in size according to the flow of blood through the organ. During an acute infection, it will become enlarged and tender. Patients with leukemia may have an enlarged, firm spleen that is palpable on examination. The spleen is filled with excess immature cells to be destroyed. Blood is the life-giving fluid of the body. It flows through the blood vessels, transporting substances essential to the maintenance of life. The average adult has 8 to 10 pints of blood. A loss of 2 pints, or about 20%, is cause for concern. The blood carries oxygen from the lungs to the body's cells, nutrients from the digestive system to the cells, and cellular wastes from the cells to the appropriate organ for excretion. It picks up hormones excreted from endocrine glands and distributes them throughout the body to the appropriate receiving organ. Blood also delivers the minerals necessary for muscular contraction, heartbeat, stimulation of the respiratory system, and the homeostasis of cells. This vital substance is composed of only 2 main parts, the plasma and the cells, but each part has many essential components. Figure 11:17. Plasma is a straw-colored liquid that makes up a little over half the volume of blood. It is about 90% water, the remainder consisting of minerals such as calcium, sodium, potassium, phosphorus, and bicarbonates. The minerals are commonly referred to as electrolytes. These elements are processed by the body from the foods that are eaten and play a major role in maintaining the acid-base balance of the blood. Plasma contains other vital substances such as vitamins, hormones, enzymes, and nutrients absorbed from the digestive system, such as glucose, fatty acids, and amino acids. Oxygen, carbon dioxide, and other waste products from the cells are also carried in the plasma. In addition, 3 important proteins are found in plasma: fibrinogen, which is necessary to clot blood; serum albumin, which aids in maintaining blood pressure by regulating the exchange of water between the cells and the blood; and serum globulin, which assists in the formation of antibodies. A substance called prothrombin is a type of globulin formed by the liver, with the aid of vitamin K. It plays an important role in the clotting of the blood. Cells. The cellular portion of the blood can be divided into 3 types of cells: red, white, and platelets. Refer to Figure 15-23. Red blood cells. Erythrocytes, meaning red blood cells, are biconcave discs with very thin centers to enable them to fold over if necessary to pass through a narrow opening. Red cells number about 25 trillion in the body, or about 5 million to a cubic millimeter of blood. It is the red cells which give blood its color. A red blood cell lasts about 4 months. They are produced in the bone marrow at a rate of about 1 million a second, the same rate at which they wear out. Erythrocytes obtain their color from hemoglobin, which is a combination of a protein and an iron pigment. It is hemoglobin that attracts and carries the oxygen and carbon dioxide in the blood. When hemoglobin is carrying a lot of oxygen, it is bright red in color. As the oxygen is given up to the cells and exchanged for carbon dioxide, the color changes to the dark reddish blue that is visible in surface veins. White blood cells. White blood cells are called leukocytes. Leukocytes are present in the blood at approximately 5,000 to 9,000 per cubic millimeter, or about 1 white cell for every 600 to 700 red blood cells. White cells are about twice the size of red blood cells. Leukocytes play a vital role in defending the body against invasion, moving through capillary walls into the tissue fluid to chase down bacteria. Leukocytes are divided into 2 major groups, granulocytes and agranulocytes, depending upon the presence of granules and certain staining characteristics. Granulocytes are produced in red bone marrow and last for only a few days. There are 3 types. Neutrophils phagocytize, meaning destroy, bacteria by surrounding, swallowing, and digesting them. Eosinophils are thought to consume the toxic substances in tissues since they are found in increasing numbers when the body has had a foreign protein injected, or an allergic reaction, or has been infected by a parasite. The 3rd type, the basophils, are also thought to participate in phagocytosis since their numbers increase with chronic inflammation or during healing from an infection. Agranulocytes are of 2 types: lymphocytes, which are produced by bone marrow and lymphoid tissues such as the nodes and spleen, and monocytes, which are formed in the bone marrow. Lymphocytes primarily specialize in providing immunity for the body by attaching themselves to foreign bodies and destroying them, and by developing antibodies. The monocyte assists with phagocytosis. Some enlarge greatly when they enter tissue and become fixed. When an inflammation occurs, white cells can divide and proliferate into capsule-like structures around foreign objects that cannot be digested, such as silica dust and carbon particles, or causative organisms of infections such as tuberculosis. This action effectively walls off involved tissue in an attempt to contain the foreign material or prevent the spread of disease. The evidence of a phagocytic reaction to invading bacteria or a foreign object is the presence of exudate, meaning pus. Exudate is composed of lymph, bacteria, and dead white cells. Platelets. The third kind of cell is the platelet. These cells are the smallest of the three and are present in the blood at a rate of 200,000 to 400,000 per cubic millimeter. They are also formed in the bone marrow from cell fragments. Platelets function in the life-saving process of clotting blood. When a blood vessel is cut or damaged, it is believed that the rough surface may catch or attract platelets to the area. This reaction occurs only when there is an incidence of bleeding. Otherwise, the clotting process would stop circulation within the blood vessels. When there is a cut, platelets pile up at the site to form a small mass. Once attached firmly to the damaged area, they release the chemical, serotonin, which causes the blood vessel to spasm, resulting in a narrowing of the vessel and a decrease in blood loss until the clot can be formed. Figure 11-118. At the same time, platelets and injured tissues release thromboplastin, which triggers the clotting process to begin. The thromboplastin cooperates with calcium ions and other blood clotting factors in the blood to convert prothrombin present in plasma into thrombin. The thrombin acts on another protein in the plasma called fibrinogen. This reaction results in the formation of fibrin, tiny threads which form a network of fine mesh fibers over the cut. This net begins to catch the red blood cells, other platelets, and plasma, forming the clot. It should be remembered that unless the cut blood vessel is small, a clot may not be able to form. The force of the flow of blood will wash away the body's efforts to form fibrin nets, and therefore will be unable to collect the ingredients of the clot. Clotting can be assisted by applying pressure over the area to stop the blood flow until a clot can form. When major vessels are cut, it may be necessary to surgically close the opening with sutures to control the bleeding. Fortunately, internal bleeding vessels can also undergo the clotting process. Complications can occur from the clotted mass, especially if the clot or its fragments break loose and enter the circulation before the body's natural housekeeping function can gradually remove it from the blood vessel. Bleeding time. The length of time required for blood to clot from an induced puncture wound is useful information when preparing a patient for a surgical procedure or evaluating the effects of certain disorders or medications. The normal range of bleeding time for the template puncture method is from 2 to 8 minutes. The length of time varies with the method used. Blood types. There are 4 types of blood: A, B, AB, and O. The type of blood a person has depends on the presence of a protein factor called agglutinogen or antigen on the surface of the red blood cell. Type A blood has an A agglutinogen. Type B has a B agglutinogen. Type AB has both agglutinogens, and type O has neither. Figure 11-119. Similarly, a protein is present in blood plasma known as agglutinin or antibody. Type A blood has a B agglutinin. Type B blood has an A agglutinin. Type AB has no agglutinins, and type O has both A and B. The term agglutinate refers to the process of clumping or sticking together. Blood clumps and causes the process of clumping blood vessels if agglutinins and agglutinogens of the same type are mixed. This reaction can be fatal. Therefore, it is extremely important to determine the blood types of both the recipient and the donor when blood transfusions are required. A laboratory test, known as type and cross-match, is necessary to make this determination before the administration of either whole blood or packed cell transfusions. Not only is the blood typed, but it is also mixed and observed to assure that agglutination does not occur. Cross-matching will also detect the presence of subtypes, and an agglutinogen, known as H. Figure 11-120 shows how the different types of blood would be distributed through 100 people as identified by the American Red Cross. The need for blood from donors is a constant concern for patients and their physicians. Information from the central area of a Midwestern state indicates that 550 donors are needed each day. That translates to 16,175 per month or over 200,000 a year. A recent survey showed that 33% of Americans feel there is a great risk of getting AIDS or hepatitis from a transfusion. Currently, with the methods used to screen donors and the tests performed on the blood, it is highly unlikely. The risk of blood-borne AIDS is now only 1 in 420,000 units of blood. Hepatitis is far smaller. A new form of hepatitis called hepatitis G has now been identified, so testing for it will be developed. To this point, 6 types have been found and more are suspected. Scientists have been trying to develop artificial blood as a substitute. One firm is now ready to test its product. Another research project has led to the creation of 3 pigs that carry genes that produce human hemoglobin, which can be extracted, chemically modified, and then pasteurized for human use. It has a longer storage life, does not require refrigeration, avoids the risks of human viral diseases, and works in all blood types. At this point, it is in the testing stage. Rh factor. Red blood cells may have another factor known as the Rh factor. It is an antigen first detected in the blood of a rhesus monkey, hence the name Rh. If the red cell has the factor, it is said to be Rh positive or Rh+. If the factor is absent, then the blood is said to be Rh negative or Rh. Blood must also be checked for the presence of this antigen when a transfusion is to be given. If an Rh negative person receives Rh positive blood, the antigen is foreign to the recipient's bloodstream. Within 2 weeks, the individual will produce antibodies in response to this invasion of a foreign substance. Usually no problems occur unless, at a later date, the person receives another Rh positive transfusion. This time, the developed antibodies will react to the antigen being received and may cause serious complications. It should be noted that persons who are Rh positive can receive either Rh positive or Rh negative blood, provided it is properly typed and cross-matched, because they already have the Rh factor. An Rh negative blood lacks the antigen. When the 2 blood samples can mix without evidence of any clumping, and the Rh factor is appropriate, the blood is said to be compatible. The Rh factor is also of concern with pregnancy. If a female who is Rh negative becomes pregnant with an Rh positive baby, a few positive cells may enter the mother's blood at delivery and cause the production of antibodies. The firstborn will not be affected, but later pregnancies, if Rh positive, may be affected by the antibodies which have been developed. These antibodies slowly filter into the fetal circulation and destroy the Rh positive red cells, making the newborn profoundly anemic and jaundiced. The situation must be treated vigorously, with steps taken to alter the infant's blood. This potentially fatal situation can be avoided by determining the Rh factor of the mother. If she is negative, then the father's factor must be determined before the first child is born. At the time of delivery, if the baby is positive, the Rh negative mother is given an injection of an Rhd immune human globulin, which prohibits the production of antibodies against the baby's Rh positive blood. Only when the mother is negative and the fetus positive is there cause for concern. If the father also happens to be negative, there is no need to treat for the antibodies unless the mother could have, at some previous time, received an Rh positive blood transfusion. In the next unit on the immune system, we will take a deeper look into the function of leukocytes and how they maintain our immunity. We will also learn more about the antigen-antibody process. Cardiovascular tests. Many sophisticated tests can be performed on the circulatory system, but most of them are best studied at a more advanced level. A few of the more frequently encountered cardiovascular diagnostic procedures will be discussed briefly here. Common studies done on blood are discussed in Chapter 15. Arteriograph, also called angiograph, a radiological examination of an artery or arteries after the injection of a contrast medium. The test is used to indicate the status of blood flow, collateral circulation, malformed vessels, an aneurysm, or the presence of hemorrhage. Figure 11-121 is an example of an artery following injection. It is often done in connection with cardiac catheterization. Coronary angiography is very helpful in diagnosis. It can reveal faulty motion of the heart wall, leakage of blood back through diseased valves, or a hole between the right and left sides. In the coronary arteries, angiography can help locate blockages, which can then be treated with an angioplasty procedure or identified for bypass surgery. About 1 million angioplasties are performed in the United States each year. Cardiac catheterization. A catheter to the right side of the heart is inserted into a vein at the antecubital space of the right arm. A catheter to the left side of the heart is inserted into the brachial artery at the left antecubital space. The femoral artery or vein may also be used, The catheter is passed through the blood vessels until it reaches the heart. When it is determined, by fluoroscopy, that the catheter is properly positioned, a contrast medium is injected to permit visualization. The heart's chambers and valves and the coronary arteries or the pulmonary artery may be viewed, depending on the site being catheterized. The procedure can also be used to measure blood pressure within the pulmonary artery and some portions of the heart. It is used in connection with coronary angiography. Figure 11-122 illustrates the usual points of insertion of the cardiac catheter. Notice the different shapes of the catheter tips, which help to guide the catheter into the desired position. Note: as of September 1996, some physicians have begun to question the use of catheterization in critically ill patients. A preliminary study showed that at 5 hospitals where evaluation was done, those who underwent the procedure had worse outcomes. The 4 things evaluated were survival, intensity of care, length of hospital stay, and total cost. The study included 2,184 persons who were catheterized within the first 24 hours of intensive care admission. Results showed that the 30-day death rate was 24% higher. The hospital stay was 15 days as compared to 13 for the non-catheterized, and the cost was $49,300 compared to $35,700 without the procedure. It is thought that the irritation from the catheter could cause thrombosis or infection. However, it might not be at fault at all, since these patients were likely to have other procedures done while in intensive care. It was recommended that additional studies be required under a strict randomization of treatment assignments in order to properly assess the outcomes. In the meantime, some physicians are recommending that the use of catheters be stopped. Others say their personal experience shows that certain carefully selected patients benefit from the procedure, providing that the physician is experienced in the insertion of the catheter, interpreting data, and managing the patient's care. Doppler ultrasonography. Sound waves are transmitted through the skin and are reflected by the cells in the blood, moving through the blood vessels. Figure 11-123. This diagnostic tool can evaluate the major blood vessels of the body to determine deep vein thrombosis, peripheral arterial aneurysms, and occluded carotid arteries. Echocardiograph. A test using ultra-high-frequency sound waves directed through the chest wall into the heart. The waves reflect from the heart through a mechanical device to produce a record of the structures of the heart and its chambers. The test evaluates cardiac function and structure and can reveal valve irregularities, defects in the interior walls, and the presence of fluid between the layers of the pericardium. Electrocardiograph, ECG. This test is also called EKG and is perhaps the most common tool used to evaluate heart performance. The ECG is a graphic recording of the electrical activity of the heart, identifying rhythm, abnormalities in conduction, and electrolyte imbalance. The graph is useful in documenting diagnosis and provides a method of measuring progression of cardiac disease conditions. The ECG also helps evaluate the effectiveness of an artificial pacemaker and cardiac medications. The test may be taken while the patient is lying in a comfortable position, or in an exercise mode such as bicycling or walking a treadmill. The exercise mode measures the effects of controlled physical stress and is referred to as a stress ECG. Frequently, abnormalities of cardiac action are more evident upon exertion. Another type of ECG is called the Holter monitor or ambulatory, meaning walking, ECG. The ECG electrodes are attached to the patient's chest wall, and a portable cassette recorder, called a monitor, is placed in a belt about the waist. For a 24-hour period, the patient's heart action is recorded, and a diary is kept of daily activities and any associated symptoms. At the end of the test, the recording is analyzed by computer and a report is printed. This type of test is most beneficial for symptoms which occur irregularly or to evaluate the status of recovering cardiac patients. Another version permits the patient to activate the recording device only when experiencing symptoms. This patient-activated monitor can be worn for several days. See Chapter 16. MUGA scan. MUGA is an acronym for multiple gated acquisition, a test to evaluate the condition of the myocardium of the heart. The test can be done in a resting or exercise mode. Isotopes are injected intravenously and are taken up by the myocardium. The scintillation camera records the motion of the heart. The test permits measurement of ventricular contractions to evaluate the strength of the heart wall. Patients who receive a chemotherapeutic drug that has cardiac toxicity side effects are monitored periodically by MUGA scans due to the drug's tendency to damage the myocardium. Stress thallium ECG, a test to evaluate myocardial blood flow and the condition of the cells. The ECG electrodes are attached to the patient before performing the stress test on either a treadmill or a bicycle. The blood pressure and pulse rate are carefully monitored. When the patient reaches peak stress, the thallium is injected intravenously into the antecubital vein, and the exercise continued for an additional minute to ensure circulation of the isotope to the heart. The ECG electrodes are removed, and within 3 to 5 minutes, the patient is positioned under the scintillation camera. The scanner records the amount of thallium uptake by the heart over the next several minutes. Areas of the heart with normal blood supply and healthy cells rapidly take up the isotope. Areas of poor blood flow or damaged cells do not take up the material and appear as dark spots on the scan. These are known as cold spots. The test is indicated for assessing myocardial condition, demonstrating the location and extent of a myocardial infarction, MY, diagnosing coronary artery disease, and determining the effectiveness of artery grafts and angioplasty procedures. Persantine thallium is a new type of stress test. It is used for patients with arthritis or any other condition that prevents a patient from exercising. It determines the presence of coronary artery disease. Venogram, a radiographic examination using a contrast medium to determine the condition of the deep veins of the legs. It is especially useful in determining the presence of deep vein thrombosis, DVT, which may occlude the vein systems and lead to pulmonary embolism. DVT may result from vein injury, prolonged bed rest, surgery, childbirth, irregularity in the coagulation process, and the use of oral contraceptives. Diseases and disorders. Anemia. Description. This term indicates that certain elements are lacking in the blood. There are various types of anemias. Iron deficiency anemia. Iron deficiency anemia is the most common form of anemia. Description. This form is characterized by an inadequate supply of iron to form normal red blood cells. When the body's supply of iron decreases, so does the number of red blood cells, and as a result, the hemoglobin. This reduces the body's ability to carry oxygen to the cells. Signs and symptoms. Symptoms include fatigue, listlessness, pallor, inability to concentrate, and difficulty in breathing on exertion. Causes. Iron deficiency anemia develops from an inadequate dietary intake of iron, or inability of the body to absorb iron, as the result of diarrhea, partial or total removal of the stomach, or certain diseases. It can also be caused by intestinal bleeding, heavy menstruation, colon cancer, or bleeding ulcers. It is most common among premature infants, children, adolescents, especially girls, and women before menopause. Treatment. Iron deficiency is treated by first identifying the underlying cause. Once determined, iron replacement can begin. Oral preparations of iron or iron combined with ascorbic acid are given. Intramuscular injections are possible but not desirable due to the discomfort produced. Intravenous infusion is relatively painless and requires fewer injections. Aplastic anemia. Description and causes. It is a disease resulting from injury or destruction of the blood cell formation function of the bone marrow. Signs and symptoms. This disease generally produces a fatal bleeding episode or a systemic infection, often as a result of infectious hepatitis. Treatment. Treatment for aplastic anemia must first rule out any identifiable cause and follow with transfusions of packed cells. Recovery may take months. Bone marrow transplant is the treatment of choice in severe aplastic anemia, and with those needing constant red blood cell transfusions. The use of corticosteroids and bone marrow stimulants is appropriate in some cases. Acute blood loss. Anemia. Acute blood loss anemia is a term that is used to describe conditions of low red blood cell count, occurring over extended periods of time. However, low red blood cell count can also occur following an acute blood loss and is referred to by some as acute blood loss anemia. Signs and symptoms. In this instance, there is a sudden loss of red blood cells and therefore hemoglobin and iron. The rapid loss of blood volume can be fatal. Causes. Acute blood loss can result from severe trauma, the inability to coagulate the blood, ruptured gastric or intestinal ulcers, postoperative bleeding, postpartum, meaning after birth, hemorrhage, or a ruptured aneurysm. A loss of 20% to 30% of blood volume causes circulatory insufficiency with symptoms of shock, restlessness, low blood pressure, rapid pulse, perspiration, and cool, clammy skin. With a loss greater than 30%, the circulatory system may fail, and be followed by shock and then coma. Blood loss beyond 40% is life-threatening, and the patient will die unless blood volume is immediately replaced. Treatment. The treatment goal in acute blood loss anemia is to control the hemorrhage and restore blood volume. Prevention of shock is very important. Immediate infusion of intravenous fluids, electrolyte solutions, and plasma can increase the circulating volume, while packed cells and/or whole blood are being typed and cross-matched for infusion. Aneurysm. Description. This is the ballooning out of the wall of an artery. Often an aneurysm is associated with atherosclerosis or arteriosclerosis, and the resulting hypertension. A slight break or weakness in the muscular layer of an artery allows the pressure of the blood to push the walls of the blood vessel out, figure 11-124. The larger the bulge, the thinner the arterial wall becomes. Eventually, the wall gives way and a hemorrhage occurs. The extent of the bleeding and its effects on the body depend to a great extent on the location of the aneurysm and the size of the involved blood vessel. Aneurysms are found primarily in cerebral arteries, the thoracic or abdominal section of the aorta, and the femoral and popliteal arteries of the leg. Some aneurysms are without symptoms and are discovered by accident or an X-ray. Cerebral aneurysm. Cerebral aneurysm occurs within the brain. Description. Depending on its location, it may rupture and cause bleeding within the subarachnoid space, or an artery within the brain tissue itself may rupture. If the hemorrhage is not too massive, the blood clots. Later, the body will slowly reabsorb the blood clots and function will return. Hemorrhage may be fatal, however, due to increased intracranial pressure from the blood, which compresses and damages brain tissue. Remember, the skull is a solid structure that does not stretch. Therefore, when bleeding occurs, the delicate tissues of the brain are displaced and damaged. Cerebral aneurysms are graded from 1 to 5 depending on the amount of bleeding. Rebleeding after 7 to 10 days is not uncommon. When the initial blood has clotted, the body resumes its normal function of removing clotted material, which may lead to a renewed and often fatal recurrence. Signs and symptoms. Usually the onset is without warning, but headache, nuchal rigidity, meaning back of neck, stiffness in the back and legs, and intermittent nausea may be present for several days preceding the rupture. Upon rupture, there is a sudden severe headache, nausea, vomiting, and maybe some altered level of consciousness including coma. Following bleeding, there may be back and leg pain, restlessness, fever, irritability, and occasionally seizures and blurred vision. If there is bleeding into the tissues, there may be paralysis, sensory deficits, difficulty speaking, and visual defects. Treatment. Treatment is directed toward reducing the risk of rebleeding by repairing the aneurysm surgically. When the patient's condition will not withstand the surgery, a conservative treatment of bed rest for 4 to 6 weeks, avoidance of coffee, other stimulants, and aspirin. Analgesics as needed, a hypotensive drug if there is hypertension, corticosteroids to reduce edema, a drug to delay blood clot destruction, and sedatives to reduce stress is indicated. Aortic aneurysms. Aortic aneurysms occur due to the great pressure in the artery. Rupture of the aorta is usually fatal. If the thoracic aneurysm begins by splitting of the wall, the person may experience a tearing or ripping sensation accompanied by chest pain, pallor, rapid pulse, shortness of breath, loss of pulses below the neck, and other symptoms. Treatment. Surgery can be accomplished to remove the damaged segment of the aorta and replace it with a Dacron or Teflon blood vessel graft. Abdominal aneurysms. Abdominal aneurysms are usually without symptoms, but are detectable on palpation as a pulsating mass in an area around the umbilicus, meaning navel. If it ruptures, the patient may experience pain similar to that of kidney spasms. About 20% of such patients die immediately. However, if the bleeding is in the retroperitoneal space, meaning behind the peritoneal lining of the abdomen, the limited space puts pressure on the tear as it fills with blood, closing off the opening. Treatment. An abdominal aneurysm is repaired like an aneurysm of the thoracic aorta. In addition, an external Dacron prosthesis, meaning artificial part, may be applied around the aneurysm and sutured into place to support the weakened wall. Aneurysms in the lower extremities may interfere with circulation and result in severe ischemia, meaning lack of blood, and gangrene, meaning tissue death, which may require amputation. Angina. Description. This heart condition causes severe chest pain that radiates down the inner surface of the left arm, usually associated with emotional stress and/or physical exertion. The episode may last from a few seconds to several minutes. Signs and symptoms. Symptoms, in addition to the pain, include irregular heart rate, lowered blood pressure, anxiety, and perspiration. Causes. The pain is believed to be caused by a spasm of one or more coronary arteries, which results in ischemia to a portion of the heart muscle. Treatment. The treatment consists of nitroglycerin, in a tablet form, placed under the tongue or applied to the body in a paste form. The nitroglycerin dilates the constricted artery or arteries to permit the flow of blood to the heart tissue. When angina pain persists after 10 minutes and the use of 3 sublingual tablets, the patient should go directly to the nearest hospital emergency room. The patient must be instructed to have nitroglycerin available at all times. Tablets must be kept in a dark, tightly closed bottle, without cotton, and be protected from heat and sunlight. Tablets over 3 months old should be discarded. Nitroglycerin has recently been produced in a Band-Aid form to permit prolonged release of the drug in measurable doses. It is also available as an oral spray. Other medications, such as calcium channel blockers, are also used to prevent angina. A new little-known procedure is being used in 25 centers in the United States. It is thought useful in about 5% to 15% of angina sufferers who are not candidates for established alternatives. It is called enhanced external counterpulsation. It involves the use of cuffs positioned around the legs, thighs, and hips. The apparatus is operated by a computer which synchronizes pulsations to the heartbeat and a compressor which inflates the cuffs, forcing blood to the arteries when the heart muscle is relaxed. This increases blood flow to the heart and decreases the workload. It requires daily 1-hour treatments for 35 days at an average cost of $7,000, as compared to $15,000 for angioplasty, or $30,000 for a bypass procedure. Figures are for a central Ohio city. At present, the treatment is limited to patients with stable angina who are not candidates for other treatments. Locally, the men treated have shown a decrease in the frequency and intensity of pain and an increase in exercise tolerance. Some have been able to resume work and even exercise. One person who could not walk 200 yards can now walk 4 miles a day, pain-free. Another former life flight paramedic has resumed his duties after expecting to retire on disability. The treatment is non-invasive but does require a considerable investment in time. However, most feel they have nothing to lose except money. At present, insurance will not cover the costs because it is considered experimental. Arrest, cardiac description. This is a complete, sudden cessation of heart action. The condition is rapidly fatal, producing irreversible brain damage after 5 minutes. Signs and symptoms. The major symptom is the sudden ending of heart function, hence the absence of heartbeat and pulse. Causes. It is believed to result from a failure in the body's ability to transport calcium, which interferes with its electrical and mechanical functions. It is associated with severe lack of blood to the myocardium. Cardiac arrest can also be caused by heart failure, electrical shock, fibrillation, drowning, anesthetics, respiratory failure, and severe electrolyte imbalances. Treatment arrest is treated initially by external cardiac massage, CPR or cardiopulmonary resuscitation technique, then supplemented by defibrillation, IV drug therapy, and ventilation procedures. Death is certain if function cannot be restored quickly. Arrhythmia description. This term is used to identify any abnormal changes in the heart rhythm. Arrhythmias vary in severity from mild to life-threatening, as with fibrillation. They are classified according to the origin of the irregularity, for example, PVC or atrial flutter. The more the heart action is affected, the greater the consequences on the cardiac output and the blood pressure, which in turn determines the clinical significance. Signs and symptoms. The presence of an irregular heart action pattern causes arrhythmias may be congenital or may result from myocardial anoxia, infarction, hypertrophy of muscle fiber from hypertension, or degeneration of conductive tissue required to maintain normal rhythm. Treatment. Treatment varies in relation to the cause and severity of the irregularity, from no treatment to medication, eliminating known causes, CPR, and the insertion of a pacemaker. Arteriosclerosis description. A hardening of the arteries and arterioles. The muscular and elastic tissue is gradually replaced by fibrous tissue and calcification. Since the vessels are no longer capable of expanding and recoiling with each heartbeat, the heart must exert more pressure on the blood to pump it through the more rigid vessels. Arteriosclerosis results in high blood pressure and may lead to an aneurysm and cerebral hemorrhage. Signs and symptoms. The major symptom is hypertension. Causes the artery and arterial walls become fibrous and contain calcium deposits. Treatment. The prime focus of treatment is aimed at preventing the rupture of an aneurysm or a CVA, stroke, by reducing blood pressure. Atherosclerosis description. This condition is characterized by the deposit of fatty material along the linings of the arteries, figure 11-125. As the material builds up, the opening of the artery may become partially or totally closed, thereby reducing or eliminating the flow of blood to the area. Atherosclerosis can also result in elevated blood pressure, but the greatest danger is a blocked coronary artery and heart attack. There is also danger from the atherosclerotic plaque deposits that can break loose and circulate through the bloodstream as emboli. Signs and symptoms. The major symptom is hypertension. Examination of the interior of arteries would show plaque of lipids and fat deposits. Decreased circulation symptoms are particularly observable in the carotid, coronary, and lower extremity arteries. Causes. Atherosclerosis is linked to many risk factors: family history, hypertension, obesity, smoking, diabetes, stress, sedentary lifestyle, and high serum cholesterol and/or triglyceride levels. Treatment. The goal of treatment is to prevent occlusion of the arteries and, with coronary involvement, prevention of myocardial infarction. Dietary restrictions to reduce intake of salt, fats, and cholesterol are indicated. Abstaining from smoking and reducing stress are also recommended. The use of angioplasty to compress, remove, or stent areas of deposit is a treatment option. With complete obstruction, bypass surgery may be indicated. Athletic heart syndrome. Description. This is a series of cardiac changes resulting from strenuous exercise. Primarily, the heart enlarges, cardiomegaly, particularly the ventricles, because of its adaptive ability to meet the body's need for increased output. Since the heart is a muscle, it reacts just as the biceps do to physical endurance training. This syndrome is increasing due to the emphasis on physical fitness. Signs and symptoms. The athletic heart usually produces no symptoms, except perhaps pounding or irregularity after strenuous activity. Bradycardia of 40 beats per minute is common and may be considered normal, due to the heart's increased efficiency upon contraction. Causes. The syndrome is probably a physiological response to maintaining optimal cardiac performance during physical endurance training. The stress placed on the heart causes the left ventricle to enlarge in order to meet the demand for more oxygen and hence more blood flow. Treatment. Nothing is required unless there is underlying cardiac disease, which will necessitate discontinuing training. Carditis. Description. Literally, it is inflammation of the heart. The term is usually used with one of three prefixes that define the portion of the heart that is involved. The inflammation results from an infectious process caused by a viral, fungal, or bacterial invasion. Other causes vary with the form of inflammation as follows. Pericarditis. Description. An inflammation of the pericardium, the fibroserous tissue sac which covers the heart. Signs and symptoms. It may result in a purulent or bloody exudate forming within the sac, or the tissue may become thickened and fibrous, constricting the filling action of the heart. Pericarditis can follow injury to the heart, an infarction, or cardiac surgery. Acute pericarditis typically causes sharp, sudden pain that begins at the sternum and radiates across the back to the shoulders and arms. It is similar to pleurisy, becoming more intense on inspiration, but decreasing when sitting upright and leaning forward. A very serious condition known as tamponade will occur if the collection of fluid within the pericardium is rapid. Pressure within the sac prevents ventricular filling during diastole, thereby severely decreasing cardiac output and resulting in pallor, hypotension, and eventually cardiovascular collapse and death. Causes. Acute pericarditis is caused by bacterial, fungal, or viral infections. Treatment. With tamponade, emergency treatment to remove the fluid by needle aspiration or surgical incision will result in a dramatic improvement. Pericarditis that causes a gradual fluid accumulation allows time for the pericardium to stretch, often to hold 1 to 2 liters of fluid. Chronic pericarditis that results in constriction or recurrent collection of fluid may necessitate partial removal of the pericardium to allow escape of the fluid. Or, if constriction, a total pericardectomy, meaning removal of the pericardium. Myocarditis. Description. An inflammation of the myocardium, meaning heart muscle. It can occur in both acute and chronic forms. Signs and symptoms. Symptoms produced are generally nonspecific, such as fatigue, palpitations, fever, and dyspnea. It is usually an uncomplicated disease and is self-limiting in nature. Normally, it is associated with a recent upper respiratory infection, URI, and fever. Myocarditis may produce mild chest soreness and a feeling of pressure, but not the anginal type of pain. Occasionally, myocarditis may initiate a degenerative process of the tiny fibrils, meaning small fibers, in the muscular tissue. This may result in heart failure, enlargement, and arrhythmia. Causes: myocarditis is caused by a viral or bacterial infection, an immune reaction such as rheumatic fever, radiation therapy to the chest, and effects of chemicals such as in chronic alcoholism. Treatment: myocarditis is treated with antibiotics, bed rest, and appropriate measures for complications that may develop. Endocarditis. Description: this is infection of the endocardial lining, heart valves, tissue adjoining artificial valves, or the blood vessel linings. In the infectious process, fibrin and platelets collect where the invading circulating organisms have produced wart-like vegetations on the valves and often the surrounding structures. The vegetative growths may cause serious complications if they embolize to the spleen, kidneys, or lungs. Causes: the infecting organism in acute endocarditis is usually a streptococcus, staphylococcus, or pneumococcus. The gonococcus is also capable of causing endocarditis. Intravenous drug abuse may lead to infections from staphylococcus or fungi, normally present on the skin surface. A subacute form may affect persons with valve or other cardiac lesions that may be acquired or congenital. Treatment: if endocarditis is left untreated, it usually results in death. Recovery is improved to 70% with proper treatment. When severe valve damage occurs, resulting complications may include insufficient cardiac action and congestive failure due to improper valve function. Damaged valves can be surgically removed with open heart surgery and replaced with artificial valves. If the infection involves an artificial valve, surgery to replace the prosthesis will be required. Often valves from pigs are used to replace damaged human heart valves and function very effectively. Cerebrovascular accident, CVA. Description: a condition commonly known as a stroke, CVA is the sudden impairment of the flow of blood to the brain, thereby diminishing or interrupting the supply of oxygen and causing serious damage or destruction of brain tissue. CVAs are classified according to their course of progression. Transient ischemic attacks, TIAs, are small, temporary interruptions of blood flow. A progressive stroke progresses, such as with a thrombosis. It begins with some neurological symptoms and worsens within a day or two. A complete stroke is at its maximum when it occurs. Approximately 1/3 of CVA patients die as a result of the condition. Signs and symptoms. Symptoms vary with the area of the brain that is involved. CVAs involving posterior cerebral arteries affect vision and often result in coma. Anterior artery involvement results in confusion, weakness, loss of coordination, personality changes, and numbness, especially in the legs. If the CVA occurs in the right hemisphere of the brain, symptoms are produced on the left side of the body, and if in the left hemisphere on the right side. A CVA may leave the patient with a variety of symptoms, which may include slurred speech, amnesia, dizziness, paralysis, one extremity, one side, or total, inability to speak, coma, double vision, incontinence, inability to control the bladder and bowels, and rigidity. Causes: a cerebrovascular accident is the result of high blood pressure, which ruptures an artery, atherosclerosis, which occludes an artery, or thrombosis, a blood clot, which interrupts the flow of blood. When a large enough area is involved, death will result. Treatment varies with the severity of the CVA, medications to prevent seizures, corticosteroids to reduce cerebral edema, achieve appropriate weight, refrain from smoking, stop oral contraceptives, if using, analgesics to relieve headache, and supportive measures such as speech, physical, and occupational therapy. Physicians now consider strokes to be an emergency. Care within the first few hours dramatically saves damage. A slogan, "Time is brain," emphasizes the urgency. Experimentally, they are being treated with blood clot busters and angioplasty of cerebral arteries, like treatment for coronary artery disease. Dissolving blood clots is not indicated when the CVA is caused by a cerebral hemorrhage. CT scans are performed to identify positively. Other drugs are being used to preserve the threatened brain tissue by slowing down the deterioration process until the blockage can be removed. All medical personnel should be familiar with the warning signs of stroke, as identified in the Harvard Heart Letter, February 1994, and listed in Table 11.5. A stroke is a medical emergency. If you see any of these signs in yourself or someone else, Even if they come and go, get help immediately. 1. Speaking trouble. Sudden difficulty speaking or understanding simple statements. 2. Vision change. Sudden blurred or decreased vision in one or both eyes. 3. Balance loss. Sudden loss of balance or coordination, especially when combined with another warning sign. 4. Weakness on one side. Sudden numbness, weakness, or paralysis of the face, arm, or leg, especially on one side of the body. Ask the person to smile. Does one side droop? 5. Consciousness change. Loss of consciousness or severe unusual drowsiness. 6. Headache. A sudden severe headache with no known cause. What to do? Do not wait. Do not drive yourself. Do not go to sleep. Call 911 or your local emergency number immediately. Note the time the symptoms started. These signs could represent a stroke. Fast action saves brain, saves function, saves life. Congestive heart failure, CHF. Description. This is a group of cardiac dysfunctions that results in poor performance of the heart with related congestion of the circulatory system. Usually the myocardium of the left ventricle is affected, often as a result of prolonged high blood pressure. Congestive heart failure can also be a complication of coronary artery disease, or a result of a mechanical disorder involving the heart's valvular functions. Left-sided heart failure. Description. Cardiac output is decreased. However, the left atrium continues to force blood into the ventricle, resulting in increased pressure and volume within the ventricle. As this backup continues, the left atrium becomes congested, backing up blood into the pulmonary veins and then the pulmonary capillary beds. The fluid in the capillaries fills the alveolar spaces, resulting in pulmonary edema. There is a lack of oxygen exchange and a decrease in the emptying capability of the right ventricle. Signs and symptoms. Symptoms of left-sided failure are shortness of breath, inability to breathe while lying down, periods of gasping for air, weak and rapid pulse, cool and clammy skin, and an ashen gray or cyanotic skin coloring. Often a cough produces pink frothy sputum. Causes. Congestive heart failure is caused by the increased pressure of blood within the heart, primarily from the poor emptying of the ventricles, which causes fluid from the blood to collect in the tissues. With left-sided heart failure, blood backs up into the lungs, releasing fluid into the alveoli. Right-sided heart failure. Description. Returning blood flow becomes congested in the systemic circulation, eventually causing fluid to enter the interstitial spaces. Signs and symptoms. Initially, the fluid can be viewed as edema in the lower extremities, but as the failure continues, edema is present in the upper extremities and in various organs throughout the system. Right-sided failure symptoms include swelling of the extremities, enlarged liver and spleen, and ascites, meaning fluid in the abdominal cavity, due to filtration from portal circulation. Venous pressure. Causes. When the right ventricle fails to move blood forward into the lungs, the blood backs up into the atrium, which therefore cannot accept incoming blood. So congestion occurs in the lower extremities and abdomen. Treatment. Heart failure is extremely serious. Treatment involves the use of drugs to quickly increase cardiac output and remove congested fluids. Arterial vasodilators increase the efficiency of heart action. Bed rest is enforced, and antiembolism stockings are used to prevent thromboembolism due to venous stasis. Continued treatment involves the use of cardiac drugs, frequent periods of rest, the use of elastic support stockings, skin care of the lower extremities, and dietary adjustments to reduce sodium intake and ensure proper nutrition. Coronary artery disease. Description. This is a disease of the arteries that surround the heart, carrying oxygen and nutrients to the myocardium. Signs and symptoms. The lack of oxygen causes the typical symptoms of angina, tightness of the chest and crushing substernal chest pains radiating to the left arm, neck, and shoulder blades. Other symptoms may be nausea, vomiting, fainting, and perspiring. When angina pain persists, it suggests an infarction. Coronary artery disease may be diagnosed by the ECG during an attack or during a treadmill or exercise bicycle test. An angiograph, also called an arteriograph, allows visualization by X-ray examination of the arteries following injection of a contrast medium into an artery. Causes. Characteristically, it is caused by atherosclerosis, which narrows the blood vessel opening, thereby reducing the volume of blood flow to that portion of the heart muscle, served by the arterial branch, resulting in angina symptoms. Treatment. Narrowed, clogged arteries can be treated by 3 methods. First is the use of nitrates to dilate the vessel. Nitroglycerin in tablet form is placed under the tongue or can be applied in a paste form to the skin surface. When medication does not relieve symptoms and arterial openings are considerably narrowed, other treatments are required. Second, an angioplasty can be performed during catheterization of the heart. A balloon-like device is inflated to compress the fatty deposits against the arterial walls, thereby opening the constricted vessel. This is called a balloon angioplasty, figure 11.126a. About 54% of the vessels clog again within 3 years and require a second angioplasty or bypass surgery. Another similar procedure is known as directional coronary atherectomy. It is performed like the conventional balloon procedure, except that one side of the tip has a metal cylinder with a cutting blade, which is attached to an external motor that rotates the cutter, grinding up the deposits and sucking them out of the catheter, figure 11.126b. This method is believed to better control the reformation of deposits. A third type of artery procedure is called a coronary stent, figure 11.126c. A balloon catheter with a stent, stainless steel mesh tube, is inserted into the artery. The balloon is inflated, compressing the deposits toward the sides of the artery and opening up the stent, which expands and stretches the arterial wall. The balloon is deflated and the catheter removed, leaving the stent to keep the vessel open. So far, it has produced the best results, reducing the need for repeating the procedure by about 40%. The main disadvantage is that the stents cost about $200 each, and most patients require more than one. Angioplasty has also been performed with a laser tip, which burned the plaque deposits, but also scarred the artery lining, resulting in quicker reclogging. A cold laser was also tried, but was not significantly better. The stent appears to be the best choice of action in most cases. However, the extent of the lesion and its location are factors in the choice of procedure. There were 367,000 balloon angioplasties performed in 1995. A third method is coronary bypass surgery. This entails bypassing clogged arteries by redirecting blood through vein grafts surgically transplanted from the legs to the heart's surface. Over 460,000 bypasses are performed each year. The replacement vessels, however, are subject to the same disease as the original vessels. Currently, 10 to 15% of bypass surgeries are repeat procedures. A new procedure uses the internal thoracic artery for the graft, because it tends to remain free of atherosclerosis longer. Coronary artery disease is best treated by prevention, which includes weight control, a diet low in salt, fats, and cholesterol, regular active exercise, reduction of stress, and refraining from smoking. Embolism description. An embolus is defined as foreign matter that enters and circulates in the bloodstream. Emboli, more than one, can be composed of blood, exudate, fat, or air. Signs and symptoms. The symptoms vary according to the location of the embolism. Obstruction of a cerebral artery has already been described in CVA symptoms. Smaller emboli produce symptoms in relation to the location and size of the mass. The first symptom of pulmonary emboli is usually dyspnea and probably chest pain. Other symptoms include tachycardia, productive cough, often blood-tinged, low-grade fever, and pleural effusion. Signs may include leg edema, massive hemoptysis, coughing up blood, cyanosis, pleural friction, and signs of circulatory collapse, fainting, and coma. A fatty embolus is potentially fatal if it is in the brain or lung. It typically occurs within 24 to 72 hours following an extremity fracture or trauma. Signs are apprehension, sweating, fever, tachycardia, pallor, dyspnea, pulmonary effusion, cyanosis, convulsions, and coma. A distinctive sign is a petechial rash, small purplish hemorrhagic spots, on the chest and shoulders. Causes a thrombus that forms within a blood vessel, becomes an embolus when it breaks loose and begins to circulate. An embolus can also result from air introduced into a blood vessel. An infection may produce a circulating clump of exudate, as discussed under endocarditis. Skeletal fractures are known to cause the formation of fat emboli. One theory holds that minute fat globules from the bone marrow enter the damaged blood vessels at the fracture site. The greatest danger of fat emboli is that they may circulate to the capillary beds in the lungs and block the alveolar exchange, resulting in an insufficient supply of oxygen. An embolus of any type is potentially lethal if the circulating mass is of adequate size to obstruct the blood supply to a significant portion of an organ. The resulting infarction, interference with circulation, is especially rapid when it occurs within a major pulmonary artery or in one of the coronary arteries, and it can prove fatal. Infarction of a kidney, the spleen, or the brain will produce symptoms related to the degree of tissue damage. If a non-vital organ is extensively destroyed, surgical removal may be indicated. Treatment. Depending upon the location of the embolus, treatment can include administering oxygen, use of heparin, reduction of pulmonary edema, chest tubes and tracheotomy to restore and support breathing, medications to cause the mass to disintegrate, antibiotics with an exudate, and other supportive measures. Hypertension. Description. In this condition, blood pressure is consistently elevated above 140/90 for persons under age 50 and 150/90 for those over 50. The severity can be gauged by the diastolic pressure, the lowest pressure during the resting phase of the heartbeat. Mild hypertension diastole is about 100 millimeters of mercury, moderate is 110, and severe is over 120 millimeters of mercury. Signs and symptoms. The presence of elevated blood pressure readings is the only observable sign of hypertension. Some people may sense that their blood pressure is high and experience headache or feel pressure. Causes. Hypertension may be classified as essential, meaning unknown cause, or secondary, meaning resulting from another disease or disorder. Essential hypertension is correlated with family history, race, higher among blacks, obesity, stress, a diet high in saturated fats and salt, oral contraceptives, and aging. Secondary hypertension may be the result of kidney disease, thyroid, pituitary, or parathyroid dysfunction, or neurological disorders that interfere with blood pressure regulation. Treatment of the primary cause will reduce the blood pressure. Hypertension may also be classified as benign or malignant. In the benign form, the pressure rises moderately over a fairly long period of time. Malignant hypertension is characterized by an accelerated, rapid, and severe increase, which may not respond to treatment. Hypertension is the foremost contributing factor to cerebrovascular accidents, kidney damage, and various cardiac conditions. Treatment. Treatment of hypertension is directed at reducing the elevated pressure and maintaining an acceptable level. It is of great importance to prevent complications of the disease. Treatment focuses on diet, control of sodium, currently being questioned, the use of diuretics to promote the elimination of retained body fluids, and antihypertensive drugs to reduce vasoconstriction and/or increase renal filtration. It is of the utmost importance that the patient maintain the treatment regimen, since hypertension is not curable, only treatable. Patients must be encouraged to continue with their medication, even though they have no symptoms of hypertension. Compliance with dietary and drug therapy is the only means of preventing life-threatening complications. Hypertrophic cardiomyopathy description. This is a disease where the walls of the ventricles of the heart are markedly thickened, sometimes to 3 times their normal width. The muscle-bound heart is stiff and cannot fill with blood and pump efficiently. It affects an estimated 1 in every 2,000 people in the United States. It is recognized as an important cause of heart failure and sudden death. Some prominent victims have been young athletes who collapse and die during sports events. The enlargement is for no apparent reason, and is not due to increased workload as with hypertension or aortic narrowing. That problem results in left ventricular hypertrophy. This disease is not to be confused with athletic heart syndrome. Signs and symptoms. Some signs include lightheadedness, fainting, shortness of breath, heart palpitations, and occasionally chest discomfort like angina. Many patients have a heart murmur. There may also be arrhythmia of the atria, and sometimes of the ventricles as well. Rapid ventricular arrhythmia or fibrillation can cause fainting and sudden death in about 2% of patients annually. Causes. In some cases, the disease is caused by a defective gene located on the 14th chromosome. This form results in 50% of their offspring developing the condition. Other causes are unknown. Diagnosis is confirmed by echocardiogram. Treatment. Most patients are placed on medication to slow the heart to encourage a relaxation phase using beta and calcium channel blockers. Some patients also require medication to control arrhythmia. Often strenuous activity is to be avoided. A new experimental therapy involves the use of a permanent pacemaker to change the heart's contraction and improve blood flow. Hypotension description. It is defined as blood pressure below the normal range. Hypotension may become life-threatening when the circulation of blood becomes impaired, and the exchange of gases is inadequate. Causes. Hypotension can result from acute blood loss, heart failure, shock, kidney failure, thyroid disease, and certain other infectious conditions. Treatment. The treatment of hypotension is determined by the underlying cause. Options include transfusion and intravenous fluid replacement, cardiac stimulants, thyroid medication, and other appropriate drugs. Leukemia. Description. This is a malignant disease of the bone marrow, called myelogenous or lymphatic tissue, called lymphocytic. Leukemia can be present in either an acute or chronic form. Leukemia will strike 94,200 Americans this year and will cause the death of 51,650. Signs and symptoms. In the acute phase, a great number of immature white blood cells are produced in the bone marrow or lymph tissue. The excessive amount of white cells cause pressure and discomfort within the bones, swelling and pain in the lymph nodes, and greatly elevated white cell count in the blood. The earliest symptoms of the disease are fever, pallor, fatigue, swelling of lymphoid tissue such as spleen and liver, and a tendency toward large bruises. Even in the presence of great numbers of leukocytes and lymphocytes, the body has little defense against infection due to the immaturity of the cells. The major complication of leukemia is infection. The disease process may progress to produce bleeding within the brain and other vital organs. In acute leukemia, the onset is rapid and death occurs within a few months unless treated aggressively with chemotherapy. Acute lymphocytic leukemia is the form common in children. Typically, it is approximately 30% into its course before it is diagnosed. Acute myelogenous leukemia is more common in adults. Both acute forms are ultimately fatal, but long-term remissions in the childhood form and approximately 70% cures are now being reported. Chronic leukemia differs from acute only in that its onset is more insidious, meaning slow, and its course is more prolonged. The median survival rate is 3 to 4 years. Signs and symptoms. Often the first symptoms are a general malaise, meaning vague discomfort, feeling bad, and weight loss. Anemia, fatigue, and greatly enlarged spleen and lymph nodes are typical symptoms. Chronic myelogenous leukemia is almost always associated with a chromosome irregularity, known as the Philadelphia chromosome. Chronic myelogenous leukemia is characterized by two distinct phases. The chronic phase, which is insidious, lasting an average of 3 to 4 years, and the eventual acute phase, an immature cell crisis, lasting only a few weeks or months before death occurs. Diagnosis can be confirmed initially by blood studies in addition to typical clinical findings. Differentiation of type and positive identification of acute or chronic forms is possible through cellular and chromosomal analysis of bone marrow aspirates. The bone marrow sample can be withdrawn through a large gauge needle introduced into the sternum, or preferably the posterior superior iliac spine. Treatment. Treatment varies with the type and form of leukemia. Systemic chemotherapy is used to destroy abnormal white cells and induce a remission so that more normal function of the bone marrow will occur. The side effects of the drugs are loss of hair, nausea, vomiting, gouty arthritis, and a number of other complications. Some success has been achieved with bone marrow transplants among siblings, particularly twins. This procedure is especially indicated in treatment of children and younger adults. Before the marrow is given, the patient is medicated with large doses of drugs to completely suppress the body's ability to react to foreign material. Total bone radiation treatments are used to induce marrow aplasia, meaning lack of function, and aid in lowering the body's resistance to the transplant. Approximately 1 liter, 1,000 cubic centimeters, of bone marrow is removed from the pelvic bones of the donor. The marrow is processed and then given to the recipient intravenously. To prevent contact with any microorganisms, the patient is placed in a reverse isolation unit. The patient is in an extremely vulnerable state, and a prolonged hospital stay is inevitable. Barring complications, which are numerous, chances for recovery are good. Murmur description. The abnormal sound of blood flowing through a heart valve can be heard with a stethoscope and is known as a murmur. The murmur is named for the valve that is leaking. Signs and symptoms. The mitral valve is the one most frequently affected, and the gurgling or swishing sound is called a mitral murmur. Murmurs are further identified as systolic or diastolic. This classification specifies whether the sound is heard during the contraction or relaxation phase of the heartbeat. Causes. Valve damage that results in murmurs can be caused by rheumatic fever, an inflammatory disease that follows a streptococcal infection. The valves may become inflamed and in time thicken and develop scar tissue. Hence, the valves lose their flexibility and no longer close completely. Endocarditis is another condition that may lead to valve damage. As previously discussed, bacteria circulating through the heart collect on the valvular surfaces, causing the growth of vegetation. and resulting in ulceration and death of some tissue. In its damaged state, the valve is no longer capable of normal function. Pre-existing valve damage from rheumatic fever, especially of the mitral valve, is quite common in endocarditis. Treatment: artificial or pig valve replacement may be indicated to alleviate the problem if severe enough to interfere with circulation. Myocardial infarction (MI). Description: a complication of coronary artery disease that results from occlusion, partial or complete, of the artery causing myocardial tissue destruction. MIs are one of the leading causes of death in the United States. Mortality is high when treatment is delayed. Approximately 50% of patients will die within an hour after symptoms develop. Signs and symptoms: it is characterized by severe crushing pain, which radiates through the chest to the neck and jaw and down the left arm. It is not relieved by rest, as with angina, and is accompanied by nausea, perspiration, a change in blood pressure, hypo or hypertension, and dyspnea. Causes: predisposing factors include sedentary lifestyle, stressful occupation, obesity, cigarette smoking, hypertension, aging, positive family history, and elevated levels of cholesterol and triglycerides in the blood. An attack can often be precipitated by a heavy meal, physical exertion, or exposure to cold weather. Treatment: treatment of MI is directed at relieving the pain with strong analgesic drugs such as Demerol or morphine, and administering extra oxygen to maintain an adequate supply to the tissues. It is important to prevent complications. Heart rhythm must be stabilized to prevent arrhythmia, which can lead to congestive heart failure. Complete bed rest must be enforced to decrease cardiac workload and prevent a possible additional infarction. Anticoagulant drugs are given to reduce the tendency to develop thromboembolism. The newest treatment includes the immediate use of a clot-busting drug to open the narrowed or blocked coronary artery in order to restore circulation to the myocardium. In about 20% of cases, this fails to work, and if there are associated bleeding ulcers or a stroke, it is prohibited. An angioplasty is now being performed on these selected patients and is being evaluated for use with other MI patients. Immediate accessibility to qualified surgeons and angioplasty within 1 hour is a problem in many areas. In contrast, clot-busting drugs can be administered immediately almost anywhere, possibly even by specially trained emergency vehicle personnel in the future. Severe complications may occur in the damaged ventricular area, in addition to the systemic threat of embolism and heart failure. Unusual and potentially lethal conditions may develop. The ventricular septum may rupture, causing a circulatory defect in which blood flows between the ventricles. The ventricular wall may weaken due to necrosis following infarction. The wall may develop an aneurysm, leading to a ventricular rupture. The patient who survives an MI will be faced with a lengthy recovery period. Lifestyles may need to be altered, and dietary and smoking habits changed. An exercise rehabilitation program must be initiated and adhered to promote optimum recovery and maintenance of a healthy state. The following information was reported in Consumer Reports on Health in October 1994. Each sentence can be long if the input requires it, but must not exceed 30 words. If a sentence is longer, split it into 2 or more natural sentences without altering the content. How to recognize a heart attack. Any of the following symptoms lasting more than 2 minutes may signal the start of a heart attack. A sensation of uncomfortable pressure, fullness, squeezing, aching, or pain, usually located in the center of the chest. A pain, aching, or heaviness in the shoulders, neck, jaw, arms, or upper back, or spreading to those areas from the chest. Pain accompanied by lightheadedness, fainting, sweating, nausea, vomiting, or shortness of breath. Taking a 325 mg aspirin tablet while waiting for help will help prevent clots from getting any larger. Clot-dissolving drugs, given intravenously within an hour of the first signs of a heart attack, could prevent about 90% of deaths. Unfortunately, half of all people wait more than 2 hours before getting to a hospital, often because they do not realize they are having a heart attack. Phlebitis description. This localized inflammation of a vein causes an alteration in the epithelial lining, which predisposes to the formation of a thrombus. Phlebitis can occur in deep or superficial veins. See thrombophlebitis for more information. Sickle cell anemia. Description. This is a congenital anemia occurring primarily among blacks, about 1 in 10 of whom carry the abnormal gene. When 2 carriers have children, there is a 25% chance that each child will have the disease. When 2 people with sickle cell anemia have children, all children will have the disease. If only one has the disease and the other is normal, all children will be carriers of the trait. Signs and symptoms. Sickle cell anemia is characterized by red blood cells with a hemoglobin defect in their molecular structure that causes them to become sickle-shaped. Cells of this shape cannot pass easily through blood vessels, and they tend to interfere with circulation. Symptoms are tachycardia, cardiomegaly, cardiac murmurs, chronic fatigue, unexplained dyspnea, chest pain, enlarged liver, jaundice, pallor, swollen joints, aching bones, and leg ulcers. Sickle cell anemia. Description. This is a congenital anemia occurring primarily among blacks, about 1 in 10 of whom carry the abnormal gene. When 2 carriers have children, there is a 25% chance that each child will have the disease. When 2 people with sickle cell anemia have children, all children will have the disease. If only one has the disease and the other is normal, all children will be carriers of the trait. Signs and symptoms. Sickle cell anemia is characterized by red blood cells with a hemoglobin defect in their molecular structure that causes them to become sickle-shaped. Cells of this shape cannot pass easily through blood vessels, and they tend to interfere with circulation. Symptoms are tachycardia, cardiomegaly, cardiac murmurs, chronic fatigue, unexplained dyspnea, chest pain, enlarged liver, jaundice, pallor, swollen joints, aching bones, and leg ulcers. These symptoms begin after about 6 months of age, when the protective excess amounts of hemoglobin present at birth are exhausted. The most common feature of the disease is a painful crisis, which usually appears first at about age 5. Sickled red blood cells become tangled, causing blood vessel obstruction and a lack of oxygen to the tissues, with possible destruction of the involved area. This tissue infarction causes severe pain in the affected area. Usual sites are the lungs, liver, bones, and spleen. The spleen, particularly, is affected so frequently that the resulting damage and scarring cause it to shrink and become useless. A crisis usually lasts from 4 days to several weeks and recurs cyclically. Diagnosis can be made from a positive family history and the typical clinical features. It is confirmed by a blood smear that shows the sickled cell structure. At present, research has failed to discover a means to prevent the sickling alteration. The disease produces long-term complications, such as delayed puberty and a tendency toward delayed growth. If the patient survives to adulthood, the body is described as spider-like, with a narrow trunk and long extremities, curved spine, elongated skull, and barrel-shaped chest. Premature death may result from repeated infarctions within vital organs or from an infectious process. Causes: it is an inherited condition due to a faulty gene. Treatment. Treatment focuses on alleviating the symptoms of the disease and on transfusions with packed red cells when an aplastic crisis occurs, depression of the bone marrow activity, and destruction of RBCs. The most successful treatment may be prevention through genetic counseling of persons known to be carriers. Information is provided to allow individuals to arrive at informed decisions regarding the conception and birth of children. There is no known cure for sickle cell anemia. However, recently, a cancer drug has been shown to help prevent the attacks. Hydroxyurea. Hydrea can cut the rate of painful episodes and complications in half, but the drug poses risks, so only adults with the most severe form are advised to take it. Stasis ulcer description. This is a secondary condition resulting from chronic venous insufficiency. The most common site of stasis ulcers is the ankle at the internal malleolus area. Signs and symptoms. Varicosities and edema are common. Early signs are dusky red deposits in the skin with itching and dimpling of the tissue. Later, there is redness and scaling of large areas of the legs. Then, cracks develop with developing crusts and ulcers. Causes: stasis ulcers develop following deep vein thrombophlebitis, which destroys the valve structures. Communicating veins in the affected area fail to compensate for the damaged vein. The venous pressure increases, causing fluid to enter the interstitial tissues and produce edema. The tissue swelling leads to fibrosis and skin discoloration from blood entering the subcutaneous tissues. The poor condition of the skin and the inadequate circulation from the area lead to a breakdown of the surrounding tissues, figure 11-127. They can also be caused by lower extremity trauma or a skin irritation. Treatment. Treatment of small ulcers involves elevation of the affected extremity, warm soaks, bed rest, and the use of drugs to counteract infection. When the swelling subsides, pressure is applied by a sponge rubber dressing or an Unna's boot, zinc gelatin boot. Large stasis ulcers not responding to treatment may require removal of the ulcer site, followed by a skin graft. Thrombophlebitis is an acute condition in which the lining of the vein wall becomes inflamed and a thrombus forms. Thrombophlebitis can develop within small superficial veins and is usually self-limiting. Deep vein thrombosis, DVT, can affect small or large veins. When there is an alteration of the vein lining, platelets begin to collect at the area. The platelet fibrin catches red blood cells, white blood cells, and additional platelets, forming a blood clot. The thrombus enlarges rapidly, particularly if the blood flow is slow, causing an inflammation that becomes fibrotic. The enlarging clot may fill the vein opening, occluding the vessel, or it may break loose, becoming an embolus. Symptoms of deep thrombophlebitis include severe pain, fever, chills, and possibly edema, with discoloration of the affected extremity. When superficial veins are involved, visible and palpable signs may include heat, swelling, tenderness, redness and discoloration, and induration, hardening, along the affected portion of the vein. DVT usually results from lining damage, but it can also follow accelerated blood clotting and a slow, reduced flow of blood. Conditions that precipitate thrombophlebitis are prolonged bed rest, trauma, childbirth, surgery, and the use of oral contraceptives. Treatment is directed toward preventing complications, controlling the development of thrombi, and relieving the discomfort. The patient is maintained on bed rest, with the affected extremity elevated to aid circulation. Warm, moist soaks are applied to the affected area. Medication is given to relieve pain, and frequently anticoagulants are used to reduce the blood's clotting ability. Anti-embolism stockings, tight-fitting, elastic, knee or thigh-length hose, are indicated to assist the return of blood from the legs to the heart. Individuals who are prone to develop thrombophlebitis should avoid prolonged periods of sitting or standing, especially with little movement, to help eliminate pooling of blood in the lower extremities. When sitting, the legs should be resting on a support that does not cause pressure to interfere with return circulation. Varicosities. Description. Veins which become dilated, twisted, and inefficient are known as varicose veins. The condition usually results from weakness of the valves in the saphenous vein and its branches, which permits blood to leak backward due to incomplete closure. As the blood accumulates, the veins become dilated. The valve is no longer capable of reaching across the opening of the vein, and the situation becomes worse. Signs and symptoms. Symptoms include a feeling of heaviness, night leg cramps, aching, and a feeling of fatigue. With deep vein involvement, edema may accumulate in the feet and ankles, often associated with the discoloration that precedes stasis ulcers. Superficial varicosed veins can often be seen or palpated behind the knees or on the medial surface of the calf. Varicosed veins are not to be confused with the tiny purplish-red surface veins seen on the skin of most adults. These are commonly referred to as spider veins and are evidence of increased venous pressure. They are often associated with varicosities. Causes. This stasis, meaning stagnation of blood, is often the result of occupations requiring long periods of standing or of other factors interfering with circulation, such as pressure against the veins during pregnancy. Treatment. Treatment for mild to moderate varicosities includes an exercise program to improve circulation, use of anti-embolism stockings, attention to sitting position, and the elimination of tight-fitting or constricting clothing such as girdles, garters, elastic bands of clothing, and knee-high or thigh-high hose. More severe varicosities may require injection of a sclerosing agent into small venous areas to scar and harden the vein. Larger involvement will necessitate surgical ligation, meaning tying off of the involved vein from its branches and stripping the vein from the leg. Complete. Chapter 11. Unit in the workbook to help you meet the objectives at the beginning of this unit and therefore achieve competency of this subject matter.